afternoon, good morning, good evening to all of you joining us from around the globe for the first conference of the World-Leading Hospitals Project. This project, initiated by ICHILOV Tel-Aviv Sourasky Medical Center, is a powerful collaboration between top hospitals from around the world, aiming to serve as a platform for sharing knowledge on global and pressing medical issues. Since its emergence less than a year ago, COVID-19 has quickly become the defining global health crisis for our times. Therefore, obviously, we dedicate the World-Leading Hospitals Project's first conference to the pandemic and its many challenges. Hopefully, today we can provide the most critical and up-to-date information from the world's leading healthcare professionals, those who are shaping the future of worldwide treatment of this unprecedented global health challenge, and are with us today. So without further ado, let's get started. Tel-Aviv Sourasky Medical Center, Israel's leading academic and scientific research medical center, has been a key player in the management of COVID-19 here in Israel. It is my pleasure to introduce the conference chairperson and the vice president for R&D at Tel-Aviv Sourasky Medical Center, Professor Eli Sprecher, for his opening remarks.
Thank you. Thank you, Dana. Welcome to all of you, wherever you are, and thank you for joining the first World Leading Hospitals Conference on the COVID-19 pandemic. This is the first edition of a series of annual conferences by the Tel Aviv Medical Center on topics of general relevance to hospitals and medical organizations. We have today with us more than 3,000 participants from more than 110 countries from all around the world, so this is really as international as it can get. COVID-19, there is so much to talk about, and we will try to cover most of it over the next few hours. The challenges, the gains, the losses, the gaps which need to be filled, and most importantly, our next moves. COVID-19 is at least the sixth global pandemic since the great influenza pandemic of 1918. And the question we should ask ourselves today is perhaps not so much as how to react to the next one, but how to avert it. Human activities and behaviors, including our relation with our environment, have been the major drivers of this pandemic. They could also be key to preventive steps, provided we all learn lessons, the same lessons, from what we have been through over the past year. And this is what we will try to do over the next 2 hours or so. So speaking of our program, I would like to deeply thank my accomplice, Mrs. Hagit Kamin, Deputy Director for Customers at the Tel Aviv Medical Center, with whom it is always a great pleasure to work with, as well as all of our team members. I would like also to very much thank Professor Roni Gamzo, our CEO, Professor Idit Matot, and Professor Ronen Ben-Ami for their help in putting together the scientific program, as well as the pro-market group for their vital contribution to the successful organization of this meeting. I would like also to extend our deepest gratitude to our speakers from all corners of the world, who through their engagement truly reflect how global this crisis has been and still is. And now, without any further ado, it is my great pleasure and great honor to introduce our keynote speaker, Professor David Rich. Professor Rich completed a residency in anesthesiology and a fellowship in cardiothoracic anesthesia at Mount Sinai in 1987. He served as the chair of anesthesiology from 2004 to 2014 and was named president and COO of the Mount Sinai Hospital in 2013. He's a prolific author of scientific papers and book chapters, was named the Horace Goldsmith Professor of Anesthesiology in 2004, and received the Jacobi Medallion in 2014. He was naturally involved in the management of the COVID-19 crisis, which severely hit New York and his hospital. As hospital president and chief operating officer of Mount Sinai Hospital, he coordinated the implementation of numerous innovative therapeutic approaches. At the time, very little was known about the disease and treatment options, and he successfully led his organization through those critical times. So, Professor Rich, thank you so much for accepting to share with us your experience and thought on the crisis and its repercussions. The floor, or should I say, the screen is yours. Thank you.
Thank you, Professor Sprecher. That was a really wonderful introduction. I thank you so much and look forward to sharing the Mount Sinai experience with the group. To move into the presentation, the Mount Sinai Health System is 8 hospitals located throughout New York City and Long Island with greater than 4.1 million annual visits, over 400 ambulatory practices, 42,000 employees, and affiliated with the Icahn School of Medicine at Mount Sinai. This is just a small before and after shot to show you this is what New York normally looks like before there's a pandemic. And this was New York at the height of the lockdown in late March and early April. So flattening the curve became a very important thing with public health measures in the New York area, hence the need for the intense lockdown. And I certainly know that the Israeli audience is very familiar with what lockdowns look like and feel like, and it's certainly challenging for all of us. This is a rather detailed timeline of what happened at Mount Sinai Hospital throughout the COVID-19 first wave. Of course, all of us became aware that there was a new problem in the world starting in January, and there was a lot of preparation in February for really not necessarily knowing what was to come. But the first patient diagnosed in New York State was actually an ambulatory patient that came, actually a husband and wife physicians who had traveled to their family in Iran and came back and had symptoms, and they came to our emergency room on February 29th, and they were actually the first couple that were diagnosed with COVID. And as you can see, by March 22nd, we had the New York pause, 6 days after schools had closed. By March 26th, you can see that we began to construct patient care spaces in our lobbies. And on April 1st, we opened a series of tents across the street from Central Park and also started using extended use of some of our PPE. I'd say that there are many challenges, but having greater than 2,000 patients in Mount Sinai Hospital was probably the greatest. But as things started to diminish with the flattening of the curve, by May 4th, we had closed the tent hospital. We had started to resume our elective surgical, not really elective, but more urgent surgical procedures on May 8th. And by May 23rd, less than 100 COVID patients. So the major challenges were increasing capacity, especially expansion of critical care, negative pressure rooms, use of the non-traditional spaces, and of course, telemedicine. Workforce management was very challenging with the supply chain problems that we had, staff training and engagement, communication, redeployment, and working towards a team-based model of care. And then testing and therapeutics, moving to in-house testing in early March was very challenging for us, but our laboratory did an amazing job, and with great luck, the Roche platform and supplies were possible for us to do that. I'll go into testing in a bit. Ventilator acquisition and management was an obsession throughout the months of March and April, and we were fairly successful with that. We prepared for a large amount of ECMO, but didn't really need it as much, and therapeutics I'll go into a bit later. And then parallel and post-surge care, a lot of it was related to the concept of not just our in-house testing capacity, but what we would do with patients after they were ready to leave the hospital setting. Could we get them into nursing homes or to other long-term acute care facilities? And communication and staff engagement is always an issue. So in the initial surge response, we had to divert resources from routine operations to increase capacity to care for COVID-19. Deferring non-urgent visits, halting urgent and all elective surgical volume, discouraging the use of resources for the asymptomatic and mildly ill, which we're shifting now towards treating the mildly ill. But at that time we could not. We deployed staff and encouraged work from home. We restricted visitation. Increasing capacity meant converting 260 patient rooms at Mount Sinai Hospital, which is about a quarter of all of our rooms, to airborne isolation rooms. And you can see on this picture that the windows were replaced with plywood panels. In those panels is a little hole, which is where the duct is attached for the HEPA exhaust fan. And that's how we converted many regular patient rooms into negative pressure rooms. We more than doubled our ICU capacity in less than 3 weeks. 8 normal adult ICUs became double bedded, meaning that we put 2 patients in spaces designed for 1 patient. We converted recovery rooms, PACUs, to non-COVID ICUs. We used an anesthesia machine fleet as a pop-up ICU on one of our patient floors, and we ended up with 240 ICU capable beds, more than doubling our normal capacity, which is about 105. incorporated remote patient monitoring outside the rooms to help our staff keep track of the patients more effectively, and of course, not just telemedicine, but cohorting both patients and staff in units where there were higher levels of infectious patients was very effective for us. The non-traditional spaces included the tent hospital in Central Park that was run by a faith-based organization from the US that drove up with their trucks and set up a beautiful facility that could care for up to 68 patients at any one time, 10 of them in a critical care setting. And also in Mount Sinai Hospital itself, this is one of our lobbies, and we see that there are construction of patient pods. Some of those patient pods are still being used throughout this winter season as an area for express care from our emergency department. There are many examples of redeployment. What you see is that anesthesiologists became intensivists, CT surgeons focused on ECMO and tracheostomies, OR technologists that weren't doing elective cases became part of a proning team, OR nurses became ICU nurses, medical students became ventilator assembly and distribution experts, and graduate students helped us and became laboratory technologists to help with the in-house SARS-CoV-2 testing. Personal protective equipment was a real problem for us. First of all, there were changing recommendations. Sometimes it felt like almost daily from the combination of city, state, and federal authorities. And our staff comfort and safety was paramount, leading to early liberalization of the use of surgical masks and subsequent N95 respirators. We had to go to extended use of personal protective equipment, meaning that someone would keep their N95 mask in a paper bag and use it for multiple patient encounters during the course of a day. We retrained our staff and refitted and tested with all sorts of different additional masks that came out. And we had tremendous pressure on our supply chain. Basically, we used 6,000 single-use N95 respirators per day, and that was sort of a normal situation that we would use. That's probably a typo, actually more than a year. We used 7,000 respirators a day with extended use. With the extended use of PPE, what you saw was it was necessary to sort of redesign the floors. These are the paper bags holding the N95 masks. And you can see that we have some green tape on the floor here, indicating that this is the clean zone. Ensuring a stable workforce meant redeploying the staff, a team-based model of care, meaning we didn't really have enough nurses for normal nursing ratios. So we used extenders, and those could be anything from a nurse anesthetist to a resident or fellow. Volunteers and external staff did come to New York to help us during this initial surge. We paid extra to our unionized employees in something known as crisis pay, and worked very hard to increase employee engagement with food donations that came from our region, providing sleeping areas for people, and respite stations, meaning areas where they could go for hydration and rest, and establish crisis hotlines. Increasing testing capacity was really an issue for us because the state and the city didn't really help us all that much with testing. We had to set up our own in-house testing capacity and try to find a stable source of reagents and supplies. And I'm going to come back to this graph a little bit later to talk about what we're dealing with currently in terms of a small second wave. But you can see in the initial phase back in March and April, which I'm circling here, there was an incredibly high positivity rate because we were only testing acutely ill people at that time. And as we moved into May and June, we can see that we moved to a background level in June, July, and August. We only had about 1 or 2% positivity rate in the Mount Sinai data, but you can see that with the expansion of elective procedures and increasing spread in the community again, that we're now increasing the numbers. We were over 2,400 tests on one day last week. Increasing ventilator capacity and innovation is something that's very important because we needed a reserve of non-traditional ventilators that could be used if we had a surge beyond our capacity with normal standard critical care ventilators. So we used anesthesia machines. We got a supply of transport ventilators. from the federal stockpile, and also some specialty ventilators. We launched a centralized assembly, testing, and distribution area using our medical student team and the simulation laboratory. And what you see on this picture on the right is we leveraged the simulation lab to facilitate some innovations. The upgrade here of a home ventilator that was upgraded to the point where it was capable of somewhat easier critical care ventilation. And we also designed a ventilator splitting protocol and even created a 3D printed valve so that we could vary the pressure that each patient would receive. Luckily, we only ever once used that in a research context with patient consent. At ECMO, we were prepared for a significant need. 20 circuits were prepared, but lung protective ventilation and proning was frankly adequate for most patients, and our outcomes on ECMO have not been so amazing that it seems like it is a very effective therapy in this disease. However, we did see some advances in terms of supportive care, becoming better over time, as you mentioned, with respiratory support in the form of high-flow nasal cannula, non-invasive ventilation, and proning. The antivirals, specifically remdesivir, became available to us, and assuring allocation and equitable prescribing was quite challenging. And then SARS-CoV-2 directed antibody therapy, specifically convalescent plasma, was something that we started doing early, even at the very end of March. And you can see in our initial data in the first 39 patients, we did see a trend towards improved survival. Actually, it was statistically significant. However, this is a cohort trial, so there is no control group. Also, of course, everyone knows about corticosteroids and anticoagulation. Anticoagulation, which was, I believe, we were one of the first areas, medical centers to report this in great numbers. But this is an example of looking at the hazard ratio for the cumulative incidence of mortality in patients who were on prophylactic and therapeutic anticoagulants. You can see that they were indistinguishable, but much improved and lower mortality than those who had not received it. This is in the very early phase of the disease when we were seeing a lot of thrombotic complications. Where did all the other patients go? I know that the same thing happened in Israel and other areas, that there was an abrupt decline in non-COVID-19 related visits with a deferral of services, and the ramifications of interrupted healthcare included what we saw in the New York region, which was an excess number of out-of-hospital deaths, probably related to everybody who did not have COVID, who was frankly too afraid to call for an ambulance or to come to hospitals. So addressing medical concerns, stigma, and maintaining capacity for a potential subsequent surge is something that we work very closely with our community on establishing good communication protocols. Continuing with COVID-19 suppression, we have proactive management of high-risk patients with frequent telemedicine visits, remote and on-site triage, visitor support persons, and escort management are all managed by policies that are driven by our New York State Department of Health. For the workforce management, I wanted to say that we have an aggressive healthcare worker management system. A healthcare worker screening and symptom attestation occurs at every entrance every day. We have a tracing capacity and occupational health capacity to deal with outbreaks that occur among our staff, and a flexible and non-punitive policy that accounts for community exposures and ensures that our workforce is not unduly burdened by periods of self-quarantine or isolation. So resuming elective surgeries actually did occur fairly effectively, and by I'd say July, after the first wave had been resolved by about a month and a half, we were back very close to a normal rolling average at Mount Sinai Hospital. The lessons learned, I would summarize as follows. We saw a lot of patients with prolonged critical illness and post-acute care needs. And so there is a need for the health system to be flexible and dynamic and to move patients around within the health system, so as people were becoming ill or becoming better, that we got them to the best beds and the best locations at any particular time. We learned that PPE works when used appropriately. Staff satisfaction and continued reassessment is so important. Staff fatigue, public perception, and continued crisis communication strategies are a constant battle for us. And remembering that everyone is someone's person, visitors are part of the healing process, and we struggle very much to this day with trying to get adequate visitation in the face of the limitations and, frankly, the concern of our staff. Coming back to that graph that I showed you before of the in-house SARS-CoV-2 testing, I want you to see that as of yesterday, we had a 4% positivity rate in the Mount Sinai data. But we're hovering right now around 3% overall. This is probably a leading indicator, but something we follow every day to see and monitor what we would expect following in 10 to 14 days as hospitalizations begin to rise. However, there are some very promising things that we saw in the second wave. And one of them is, if I can show you here on the slide, that if we look at the people who were ever intubated during hospitalization, before July, it was 17%. From July 1st onward, it was 9.2%. When we look at the length of stay in the hospital, the mean is 11 days in the first wave and 9 in the second wave. And most reassuringly, the percentage that died during hospitalization was 20% in the first wave and 5.1% in the second wave. These data are censored at 30 days so that since we know that deaths follow hospitalizations by several weeks. Also very reassuring that we see an increase in the number of patients discharged alive to home and a decrease in those correspondingly that are discharged to facility. So our new challenges are staff outbreaks, creating safer break rooms and meal behaviors, daily wellness assessments, and pushing influenza vaccination. Our treatment of clinical COVID is an evolution. Monoclonal antibodies, both ambulatory and inpatient, are on the horizon, such that we anticipate beginning the Lilly drug, the bamlanivimab treatment, with a very limited supply, and we expect that that will happen as early as this week, possibly even tomorrow. We're about to begin research trials of hyperimmune globulin, and our treatment protocols have evolved for both antibody therapy in the form of inpatient convalescent plasma, and now moving towards outpatient antibodies as well. Remdesivir, steroids, and anticoagulants for the inpatients, all logistically challenging, but helping us be very well prepared, we hope, for a second wave. As everyone knows, monoclonal antibodies are a very effective form in other diseases for prophylaxis, so post-exposure prophylaxis and early treatment in ambulatory patients seem to be the most effective therapies. Possibly early hospitalization prior to antibody formation may be useful. Currently, we do a rapid antibody screen on all patients before considering them candidates for convalescent plasma. The inpatient clinical trials include the oral antiretroviral AT527, the Freedom COVID-19 anticoagulation randomized controlled trial, the Prevent randomized controlled trial evaluating the role of pacritinib, an oral kinase inhibitor in preventing progression to critical illness, ravulizumab, a complement inhibitor, mesenchymal stem cells, and tenecteplase in patients with severe COVID-19 and poor oxygenation in the critical care units. The vaccine is on the horizon, or vaccines. We have purchased many refrigerators and are working closely with our health system and in city and state to determine a vaccination strategy, starting most likely with healthcare workers and extremely vulnerable patients, such as those who reside in nursing homes. We collect plasma for hyperimmune globulin and are working closely with a company in Canada, Emergent Biosolutions, to develop hyperimmune globulin treatments. And I will end by thanking you, all of you, you healthcare workers. You're all fighting for our lives. This is a remarkable time in our medical careers. Obviously, nothing has ever happened like this to any of us in our lifetimes. And I'm just so impressed at how people around the world have risen to the challenge. And I want to thank you very much for allowing me to give you this presentation.
Thank you, Professor Rich, for honoring us with that very insightful keynote presentation. And now to our opening panel. Decisions about medical care during a pandemic are shaped by opposing forces. On one side is the age-old directive to first do no harm, yet, on the other, an imperative to act swiftly and decisively to provide urgent care for the sick. Faced with an unknown and all too often fatal disease, the choice is hard. Either wait for controlled trials to yield clinical, useful data, or to press forward with promising but unproven therapeutics. Such decisions were never as critical as during the first year of COVID-19 pandemic. So it is truly intriguing to hear from the first-hand experience of our panelists. 4 experts in the fields of medical virology, infectious diseases, and clinical trial who will share with us their insight on key epidemiological and clinical questions about COVID-19 and outline the challenges that lie ahead. So joining us from leading institutes around the world, Professor Maria Zambon, Director of Reference Microbiology Service at Public Health England and head of the UK World Health Organization National Influenza Center, Professor Jesus Rodriguez Baño, head of Infectious Diseases Division, Virgin Macarena University Hospital in Spain, where he is coordinating the clinical team for COVID-19, and Professor Jonathan Javid, Professor of Ophthalmology at Johns Hopkins University. And the host of this panel is Professor Ronen Ben-Ami, Director of Infectious Diseases Division at Tel-Aviv Sourasky Medical Center. Professor Ben-Ami, the floor is yours.
Thank you, Dana. And thank you, Professors Zambon, Rodriguez Baño, and Javid for joining me today. I will have specific questions for each one of you, but before I get to that, I would like to get your opinions about the recent news that we've received this week on 2 clinical studies on vaccines for COVID-19, both reporting extremely high rates of vaccine efficacy. The Pfizer vaccine with 90% efficacy and the Moderna vaccine with 94.5% efficacy. And my question is, when you look at those results, what questions do you think that we need to ask to really understand whether this is a breakthrough, whether this is a game changer or not? So let me just address this to each one of you, and we can start with you, Professor Zambon.
Well, thank you very much. I think the first thing to say is it's obviously very welcome news and gives opportunity for optimism, which is something that we need in this dreadful crisis. There are many, many questions arising from this, but just think and reflect how much better it is to have the first results being results which can deliver some optimism, as opposed to hearing, oh, here we are, the first 2 trials have reported, and actually the vaccine effectiveness looks rubbish or moderate or modest at best. So I suppose my reflections are that this is evidence of good progress, and certainly really a testimony to how hard people have worked to accelerate new candidate vaccines all the way from the drawing board into phase 1 and beyond trials to demonstrate efficacy at this stage. Many, many questions about how to deploy, longer term performance, duration of immunity, and all of those kinds of scientific questions. But certainly I think my first instinct is it is welcome news, not to be taken uncritically, of course, but nevertheless welcome. Over.
Excellent. And Professor Rodriguez Baño.
Yes, well, I fully agree with what Maria explained. I think that this is a very good example of a reality that we are living in this pandemic, in which we have a public involvement of opinions and information, and the scientific and application parts of any information that comes around. So I think that the ones who are in the scientific part, we need to be very careful. We need to wait for the data. We need to be able to see them, criticize them, and then take decisions about how to applicate whatever information is coming. This is another example. We have previous information about press releases for drugs, etc. And so I think we need to be careful about any information coming. I fully understand that in a situation in which the whole world is very much worried about it, any optimistic information is useful and can be useful, but I think we should be careful about hyper-optimism or how to implement any information coming from press releases or information like that.
Okay, well, let me just focus on one point regarding those news. When we say vaccine efficacy, we are talking about prevention of clinical disease. We're talking about prevention of COVID-19. But another aim of these vaccine trials was to look at asymptomatic infection. Is that an important outcome when we think about a vaccine, not just to prevent disease, but to prevent community transmission, to actually try to curb the epidemic? Is that something that plays into this? Maybe this is most relevant to Professor Zambon.
I'm sure my colleagues will add things to this. Design of vaccines often has different goals. And in the case of COVID-19 vaccines, I think one of the first goals must be prevention of severe disease. Now, preventing disease through use of a vaccine is not always the same as preventing transmission. And there may be different ways that you approach those two scientific goals. A good example would be with influenza, where the use of live attenuated influenza vaccine is intended to provide both direct benefit to those receiving it in childhood, as well as indirect benefit to people who are prevented from acquiring infection because the vaccine acts to prevent transmission. And that you contrast with vaccines which are given to elderly, where you're actually preventing or hoping to prevent severe disease. So with COVID-19, the main goal here in the first instance has got to be to design vaccines which prevent severe infection and the consequences of severe infection. So in the UK, for example, something like 80% of all of our hospitalizations and deaths have been in the over 65s, and that's a key target group for vaccines. And that, when we're looking and thinking about how to implement vaccines, we're primarily thinking about how to prevent disease, although we do want to see vaccines which will help with transmission. And that is where your question about the asymptomatics come in, because asymptomatic individuals are probably extremely important in the overall sort of impact of COVID-19 and in terms of how much they contribute to disease transmission. And clearly, if you interrupt disease transmission, you will therefore also affect the amount of severe disease. But it's important not to muddle up those two quite different objectives. Over.
Okay, excellent. Professor Javid, short-term goals and long-term effects, what can we anticipate from such a vaccine? And do you think that anything can be learned from these results regarding the durability of protection?
Well, I think we know from these vaccines that they have short-term potential to achieve immunity against the SARS-CoV-2 virus. And that's a very important first step. The problem is we're already seeing that people who have natural immunity to the SARS-CoV virus, in other words, they've recovered from COVID-19, frequently have only short-term immunity. We're already seeing people get reinfected by the same virus, which is not something that we're used to seeing with influenza, which is not something we're used to seeing with any of the lethal pandemics that humanity's been confronted with in the past. If you got smallpox and survived, you didn't get smallpox again. If you got measles and survived, you didn't get measles again. But now we have people who have survived COVID who get COVID again. So the first thing we're going to have to learn is whether these vaccines have acceptable duration of action. The second thing we're going to have to learn is whether these vaccines against SARS-CoV-2, as we first encountered it this year, will be effective against SARS-CoV-2 as it mutates. We're already seeing a strain of virus in Scandinavia that's caused massive extinction or massive eradication of the mink population because we're seeing that this strain of SARS-CoV virus is different enough from the original strain we encountered to be a whole new threat. So just as the flu changes from year to year and vaccine technology has to change from year to year, we don't know whether we can stay ahead of this virus as it mutates. And last of all, we have no idea what the complication rate of this vaccine is going to be because it's only been given to a limited number of people. But we've already seen situations with influenza vaccines where the complication rate was far worse than we expected it to be. So we're going to have to be as optimistic as possible, but as realistic as possible.
Okay, thanks. Professor Rodriguez-Baño, I would like to switch gears a little bit and talk about treatment, and this is something that you're very much involved in. Could you tell us a little bit about the process that you have gone through as someone involved in COVID-19 from the first stages of this pandemic, where we basically knew nothing, had very limited information about the disease itself, and knew nothing about the effectiveness of various therapeutics? And how did you go into this kind of clinical field where you had to try and establish the utility of various therapeutics and also to generate data, to generate knowledge?
I think that we've lived a unique situation during I would say, the first wave of the pandemic in big part of the world in terms of taking decisions with hundreds or even thousands of patients without having any evidence about how to treat them. So I think that probably two important aspects here is, first is how to take decision in that specific situation. We have to be aware that the first results of the big trials came out after the big first wave has passed, particularly in Europe, I would say. So we have to take decisions with this many thousands of patients without much information. So how to take decision in that. And the second is how to evaluate upcoming studies, data, many of them with many limitations, in order to inform our decision during that time. So for the first issue, I think that what may be helpful for the future is first to have availability of participating in randomized trials, which are designed in a way that make it very feasible. I think that solidarity trial, recovery trial are very good examples of that. There were trials in which participating was easy, including the patient was easy. There was a very low level of bureaucracy, and that was very helpful. But it should be open to more hospitals, probably, in a way to increment the number of hospitals that have access to that. If you work in a hospital where you don't have access to trials for whatever the reasons, then probably the best way to react would be to try to write down a local protocol, a local guideline, in order to collect all the information with whatever the decision that the group of experts in the hospital have taken, if possible in agreement with other hospitals, and then try to collect very specific and very careful data to inform future decisions in related to adverse events, related to potential ways of efficacy, and try to analyze them and provide them to big cohorts. The second aspect is how to evaluate upcoming information. So we have to be very careful. I think that we learned that data coming from, I would say, low quality studies have to be very critic in their evaluation. We need to avoid taking uninformed decisions or decisions informed based on those. And if we, in whatever the hospital, the group of experts decides that after reviewing the information, this is a treatment that we can use, informed consent from the patients, approval from local ethics committees, and protocolized decisions probably will be helpful for the future. But as I said, what is very important is that we can perform randomized trials in a very efficient, a very easy way so that everybody can participate in them.
And to do that, we need to remove certain roadblocks, right? In terms of regulation, we need a pragmatic design, which isn't really germane to the way that clinical studies are being done routinely. Would you agree with that? Well, I would like to ask you about the solidarity and the recovery studies. Eventually, the results of these studies have been such that we have positive data regarding dexamethasone, and we actually don't have positive results for almost any other drug, including the antivirals that have been going through clinical studies. And I wanted to ask you, and this is really an open question, maybe we are missing something in the way that we're doing these trials. Are we not capturing the right window of opportunity to treat patients very early on before they are hospitalized? Maybe we should be doing more combination studies, thinking about this illness in terms of treatment of HCV and HIV, for example. What do you think?
Well, I think, sorry.
Would you come to me with that one next?
Well, maybe if I could start. I think one of the things that's become, we have more knowledge now than we did 6 or 7 months ago. And that may help us in designing better approaches to clinical studies generally. So as I think it's becoming apparent, there are phases to this illness following COVID-19 infection. There's a very early stage of illness where there are good opportunities to intervene through antiviral strategies by reducing the amount of virus present and potentially intervene against innate immune responses. And there are probably 4 or 5 days in which to do that. As the course of infection progresses, so the course of illness also progresses, and there are different kinds of responses that need to be tackled, potentially with different therapeutic approaches. And it may be that we are looking at trials, or we should be looking at trials, which we segment the kinds of approaches that are done based on time post-illness, where you can think of things to bring in to actually treat infection at different stages. So what I'm saying is it may not be that there will be one solution or one magic bullet, but that there are early approaches which will work to damp down viral replication and then prevent end organ damage. And then there may be things that have to be done later on to prevent immune escalation or to damp down harmful immune responses. And they're kind of different strategies that need to be taken. I'm sure colleagues would wish to comment further, but one general point where I think that the recovery studies have been incredibly successful, which is a system-wide approach with a permissive environment for clinical studies and, if you like, very simple endpoints to help guide decision-making about what is useful, and then strictly prioritized adaptive trial designs which allow any potential or new things being trialed as information comes out over.
Well, the challenge is you can do the most dramatic trial design in the world, but if you're trying the wrong drugs, it's not going to help. There's an old joke about a guy who's crawling around under a street light, and somebody says, "What are you doing?" And he says, "I'm looking for my car keys." And he says, "Well, where did you drop them?" He said, "Well, down the street over there." He says, "Well, why aren't you looking there?" He says, "Well, it's dark over there, so I'm looking over here." You know, at the beginning of the pandemic, the pharmaceutical industry jumped in and said, COVID is cytokine storm. Everybody knows it's cytokine storm. So they took a whole pile of arthritis drugs that didn't work very well for arthritis and anti-inflammatory bowel disease drugs that didn't work all that well for inflammatory bowel disease and said, these are going to work for COVID. And it's now 6 months later, and we found out that COVID is probably not primarily cytokine storm. Probably it starts out with collapse of the alveoli in the lung. It starts out with failure of the respiratory unit in the lining of the lung. And until we have drugs that specifically target that mechanism, it doesn't matter what you put into clinical trials, the clinical trials aren't going to yield a cure for COVID-19.
And Professor Javid, it would be interesting to hear, I think, your take on clinical trial design or clinical trial strategy within a pandemic versus other more conventional situations. When you go into this, what are the specific challenges or circumstances that you're faced with when you conduct a clinical trial in these settings?
Well, I'm a bit of an iconoclast, and I'm a bit of a rule breaker. You introduced me as a professor of ophthalmology, which is true. I'm honored to be thought of that way, but I'm also a graduate of the Harvard School of Public Health. And, you know, first day of class, they said, well, we're going to teach you to be epidemiologists, but you're probably never actually going to see an epidemic. Unfortunately, they were wrong. And we're having to invent the rules as we go along. You know, one thing we did when we started working with our drug is we simultaneously started a randomized control trial using conventional technique, but side by side, we started an open label study in the worst of the worst patients, the patients who were too sick to be randomized in the blinded study. And it's the open label patients so far who have taught us the most. They've shown us where you can get dramatic recovery, where you won't get dramatic recovery. They've helped us fine-tune the endpoints for the clinical trial as we've gone along. And had we just done the randomized from the first patient approach and don't look at anything until you've filled your sample size, until you've met your study power, we probably would have made some huge mistakes along the way. Yeah. So we really have to reinvent the way we're doing clinical trials and be willing to be daring and be willing to take a look at non-randomized open-label data so that it teaches us about the disease.
Well, thank you. That's fascinating. So unfortunately, our time is up, and I would like to thank all of you for joining us for this fascinating discussion and return the podium to Dana.
Thank you all very much for being with us this afternoon and sharing with us your experience and expertise. And now to our next session. The COVID-19 pandemic entails many negative aspects. However, it does bring with it several positive elements as well. For the visionaries in the field, i.e. our next speakers, this crisis can serve as a springboard to advance the way we practice medicine in several dimensions: technology, human-centered design, multifaceted clinical scenario. To discuss these dimensions and more, it is my honor to introduce our next speakers, indeed visionaries and leaders in their field. Joining us from the Department of Intensive Care in Erasmus University Hospital in Belgium is Professor Jean-Louis Vincent. Also joining us is Professor Paolo Pelosi, head of the Anesthesia and Intensive Care Unit at the IRCCS San Martino IST Hospital in Italy. And I also welcome Professor Gernot Marx, head of the Department of Intensive Care Medicine and Intermediate Care at the University Hospital RWTH at Aachen. And finally, to host this panel, it is my pleasure to introduce Professor Idit Matot, Chair of the Scientific Committee of the European Society of Anesthesiology and the Director of Anesthesia, Pain and Intensive Care Division here at the Tel-Aviv Sourasky Medical Center here in Israel. Welcome to you all. Professor Matot, the floor is yours.
Thank you, Dana. It's indeed my privilege and honor to host this section of the conference that addresses the clinical aspects of the pandemic, and even more honored to host our three prestigious speakers that join us from around the world, from Germany, from Italy, from Belgium. Thank you very much for taking the time in the midst of heavy clinical workload to share with you your thoughts and experience. And before we go into your presentation, I'd like to make a quick round and ask each one of you, now that you are already 10 months into the crisis, give me one point that you feel smarter now than when you were at the start of this pandemic. Let's start with you, Professor Marx.
And the one thing, sorry, can you hear me now?
Now we hear you.
Okay, hi Edith.
Hi.
Pleasure to be with you and on this panel. And to answer your question, the one thing I will report later on in my presentation is really the added value I have experienced in the last 10 months is really that we have now digitally networks to support each other, and this is round the clock, and I think that makes a huge difference to just acting on your own department, and this is what I feel is a plus.
You became
coming
smarter. All right.
Yes.
Okay, Professor Pelosi, your turn.
It was a great challenge in terms of organization of the structure and of the whole healthcare profession within the hospital and outside the hospital.
Professor Vincent, it's yours. The stage is yours.
We have learned a lot about the disease, and we learned especially that this is not only a pulmonary problem. It is a problem of multiple organ dysfunction. All organs may be involved, and the coagulopathy, the alterations in small vessels, in the endothelium, are very important issues that may result in major therapeutic changes.
Well, on a personal level, I have to admit that, I don't feel that we are smarter or I'm smarter. I feel more like we're on a learning curve, kind of, because at first we knew to intubate early. And then 1 or 2 months into the pandemic, we were very impressed with the happy hypoxemic patients and would rather keep them for days on high-flow nasal cannula or BiPAP or intubate them late. And we intubated late actually mainly when they were crashing. But with time, we realized it was associated with a worse outcome. And currently, we're right back where we started, i.e., we do intubate them much earlier. So I don't wish to say that we're confused, but we are still on the learning curve. But let's move on and a story. When the COVID-19 peaked in China, I took the liberty to contact my counterpart in China, i.e. the president of the Chinese Society of Anesthesiologists, who generously shared with me some of his experiences. He also taught me that the Chinese word crisis is composed of 2 Chinese characters, and they are wei ji, signifying danger and opportunity. I still remember Professor Pelosi. He was actually here with Professor Vincent in a meeting here in February when it just started. 2 weeks later, the whole world looked different. So I ask you now, gentlemen, can you identify any opportunity in this pandemic? Or as Monty Python phrased it, always look at the bright side of life. Is there any bright side to this pandemic? Let's start with you, Professor Marks. Can you please upload the slides of Professor Marks?
Okay, so I will tell you about our telemedical network, Tele-ICU, and I think this is even worthier in COVID-19 times. Next one. So we just finished, beginning of the year, a large telemedical study. Next one. Yeah. Including more than 150 patients, 10,000 ICU patients, 140,000 patients in GP practices. And we could show here that there is an increase in quality of sepsis therapy, RDS treatment, and also application of antibiotics. Next. This was the basis that in our region, which is called North Rhine-Westphalia, we started now the virtual hospital in North Rhine-Westphalia, which is supposed to be a nationwide digitally supported care network, not only for ICU, but also for oncology, rare diseases, heart insufficiency, and so on. And this will be connect patients and colleagues to experts in different areas and centers, ensuring the availability of medical expertise for all people in our area. Next. Then came the corona pandemic and COVID-19. In our area, we have 320 hospitals with ICUs, comprising more or less 5,500 ICU beds, but only nearly half of it are in level 3 centers. We all know that COVID-19 patients basically need level 3 center support, but we were expecting many patients, so needing all available beds, also the beds in the departmental hospitals. And therefore, we started this virtual hospital earlier. Next one. And therefore, here in 2 centers, in Aachen and in Münster, we are available now for all these hospitals 24 hours and support with the expertise from the bedside, which we learned because, for example, Aachen was one of the first university hospitals in Germany. We had one of these hotspots nearby, Heinsberg, and we were confronted very early with COVID-19 patients on ECMO, etc. And we could establish in a couple of days, because of our previous experience, data secure network with all technology, electronic files and communication, and obviously audio video as well. And next one. And therefore this was now established, and we are in contact with 78 hospitals, as you can see here, all around the area. Next. And we have a platform. You can reach us, as I said, 24 hours and get within 30 minutes a file, and then you have an audio video connection and getting expert support. And next. And here just one couple of examples where we are talking about infectious disease specialists, ventilation, obviously, prone positioning, protection gear was, in the beginning, a lot of anxiety was present, and we could share our expertise we already have collected, and also now obviously with the new therapies available, and also applying anticoagulant therapy. Next. And we have performed so far now 1,100 teleconsultations, and this was associated with an outcome which was 22% mortality in COVID-19 ICU patients. This is compared to the nationwide experience, which was about 50% of the ventilated patients, a quite good indication that this really makes a huge difference in outcome. And we were going to publish that very soon. Next one. So basically, our politicians were very happy because they had really an advance in healthcare system now available, which is based on digital innovation. Next one. And here just a few pictures. And if So it's really working very easily. You just need a laptop with a camera and a microphone. That's it, what you need. Next one. And this is our vision: establishment of a modern, high quality patient care, regardless where you are. Where you are. So even in rural areas, that you have access to expert advice. And I think here really COVID-19 helped to speed up this very exciting innovation. Thank you.
Thank you, Professor Marks. I have one question. If we wish to implement this system in Israel, just give us an idea. How do you record or document these consultations, and how do you protect yourself from from liability?
In terms of liability, it's an expert advice. So it is the patient of the colleagues in the rural hospitals. So we're just giving advice. So in terms of liability, it's not more. And in terms of technology, this documentation, we're using an electronic file system, so which you get sent also. So you put your data in, and I see it on my side as well. Also, X-rays, films, whatever.
And you also communicate with ICU nurses?
Yes. From our side, it's rather physician-based, but on the other side, quite often there's also ICU nurses.
Thank you. We are a bit short of time, and we need to move on to another advancement promoted by the corona, which, not surprisingly, focuses on the physician, and this time, the anesthesiologist. So, Professor Pelosi, you argue that COVID-19 pandemic served as a wake-up call for the anesthesiologists worldwide. So instead, anesthesiologists being the doc behind the scene, playing a supporting role, we have moved forward, right, to the front line as primary care physician. I can't agree with you more. So the stage is yours, and please upload the presentation.
Thank you very much. It's a great honor to be here. If I can have the first slide. So, yes, you can move on. So, next one, yes, usually next one, the anesthesiologists are considered the ghost. They are just, next one. Unfortunately, they are animated, so you can move. So they are usually hidden behind a cloth. They just make patients to sleep, are not very popular among patients, and are not much considered. But really, anesthesiologists in general are not really ghosts. And I'm just talking about the experience in Italy. Next one. Next one. And I remind you, this is an old document, next one, where it was written by colleagues in the United States in the 30s that it appears evidence that many physicians are totally unaware of the kind of knowledge of anesthesiology as at his command. The next one. And so usually we are the unknown people in the media, and especially in many countries. Next one. And as shown here in the School of Anesthesia in Chicago against many years ago, it's shown how many competences are related to anesthesiologists, even in critical care field. Next one. And just to remind you, if you can move on, this is a famous person, is John Snow, who developed the stages of anesthesia. And this was, just stop here. This was one of the first to develop the contact tracing in the cholera research in the 1848 in London. Next one. This was an anesthesiologist. Next one. And it was the foundation of the modern contact tracing. This is another anesthesiology you know very well. Next, you can move, is Ibsen. This is again anesthesiology, a pioneer of intensive care in the polio pandemic in 1952. So this is anesthesiology beyond the operating room. Next one. And again, this is the pandemic for SARS, and you can move fast this with animation. And from anesthesiology experience, you can see here how many procedures were developed that are really very effective even during COVID-19. So really anesthesiology beyond the operating room. Next one. And we know that you can move this, animate this slide. And you can see here that there are many competencies in terms of anesthesiology, and this has to be considered, especially in countries when we have anesthesiology linked with critical care and not as a separate discipline. That's, of course, in other countries. This is really, is not a specialty, but an attitude. When you enter, you never leave this wonderful world. Next one. And we know that the training is 5 years in most of the countries, and we are fighting not to reduce the training in this in most of the countries for anesthesiology in order to keep inside intensive care, and eventually 1 year more for further training, and eventually more for increasing competence. Next one. And more than 75% of intensive care are related, are led by anesthesiology in Europe. So this is an issue that, this was an opportunity for anesthesiology to showcase their skill, since anesthesiology, at least in Italy, are trained in all areas, anesthesia, reanimation, critical care, and pain medicine, not only in Italy, and also in other countries in Europe. So with a broad knowledge, most patients require non-invasive respiratory support and mechanical ventilation. Next one. The procedure has to be performed by experienced physicians. Next one. Support of general colleagues, of course, is very important. Next one. And also the transfer of patients from hospital to hospital. And next one. Teamwork is very important, of course, in this setting, and anesthesiologists are skilled for these procedures. Next one. So you can see that also we manage the no COVID patients. So that means that we believe that among the different competence, anesthesiologists have a very good competence to lead the pandemic, since, as you can see, there are many different aspects to be considered. Next one. And especially because there is a continuous pathway from the ward, intensive care, intermediate care, follow-up. So the flexibility, I think, is the word that is needed in pandemic, and not too much restriction in terms of professionality. Next one. Next one. This is when we call the patient. Next one. So anesthesiology is coming from an octopus without different, if you can come back 1 second, because this I think is an important concept. That is anesthesiology as an octopus, and you see here that now anesthesiology is becoming an octopus with, in which different areas has to be covered in this experience, which I think is very important in condition of emergency and pandemic like this. Next one, I'm almost at the end. So anesthesiology are there. This was the experience in Italy, but I think in many other countries, and I think this has to be important from our discipline. Next one. Next one. So you can move this. We have new opportunities for innovation. Next one. Adaptation of the different situation, visibility. We have to go towards Netflix. Of course, we have to generate respect among all our colleagues from different disciplines. Next one. And of course, the attitude and professionality is very important. The future, I think, for anesthesiology is the role of women, which are increasing in our discipline, very important, and the new generation of anesthesiologists to be more competent in the fields. Just the last, this I like is my last slide from Tiziano Terzani. If you can move these slides, that I always read to my students, that there is always, when we are at a crossroad and one is going up and the other take down, it's easier to go downhill, but it's then you find in a hole. There is hope to rise. It's hard, but it's always, it keeps you alert. Just the two last thick for concluding my talk that say that I think that anesthesiology with its flexibility may play a major role in pandemics. Thank you very much.
Thank you. Professor Pedlosi, you were the chair of the, actually the president of the European Society of Anesthesiology and Intensive Care in 2010, 2011. 10 years passed since. Do you have any other ideas of how to promote, better ideas than 10 years ago, okay? 10 years have passed. How to promote the anesthesia profession around the world? Very short answer, but I'd like to hear you.
Yes, just this is our genetic problem, since we are more used to work most often as a singular person.
Yeah.
We have to realize that we are really a teamwork, not only in intensive care, but also outside intensive care. And we have to promote that anesthesiology is a specialty with extreme flexibility that has to be considered, I think, more and more also from a political point of view in the organization of healthcare
I just hope that in the
anesthesiology beyond the operating room.
I just hope that in the post-COVID era, we still keep this, you know, elite unit spirit, as I call it. All right. We're approaching the end of this panel, and there is no better way to do that than to invite Professor Vincent, the walking encyclopedia of critical care. More than that, a visionary physician that inspires generation of students, residents, seniors, chairs, to discuss the multidimensional clinical challenges of the COVID-19. Please.
Thank you very much, Edith. It's a pleasure to share some thoughts with you. I think we learned a lot about COVID-19, and we are still, as you say, on a learning curve. We still learn almost every day about it. So
Can
we
you put
are
the presentation?
Yeah, please.
Okay.
So I will limit my considerations and summarize them in 4 P's: preparation, progress, personalization, and prioritization. Preparation. In the intensive care unit world, we have been relatively good at preparing our ICUs to admit these many patients, expanding ICU beds in the hospital, in intermediate care units, and even on regular floors, sometimes in the operating room, being transformed into an acute care room. You can leave the slide there if you like. We have been very good at calling on people working in other departments to help us in the ICU, because the issue was not only the ICU beds. In Brussels, like in many other places, there was a lack of professionals, not only doctors, but also nurses, physiotherapists for the CPAP systems, etc. So we have been very good at it. We have made a lot of progress, understanding the pathophysiological alterations, understanding that there are major issues with coagulation. We needed to give more anticoagulants to prevent clot formation. In terms of therapy, we have not been so good yet. We were stuck with hydroxychloroquine, which was obviously not effective in COVID. We only learned that corticosteroids and dexamethasone in particular can bring a benefit. It's not a major benefit, but it's beneficial. We could have done much more to develop new strategies. Remdesivir is moderately efficacious, and unfortunately, we do not have any other effective antiviral therapy. Personalization is very important. As you indicated, Edith, we first intubated too early, then too late, and finally we realized that we need to personalize these decisions. Simple protocols will not work for every single COVID-19 patient. So sometimes we need to intubate early, especially when there is what we call silly self-inflicted lung injury by excessive respiratory movements. And sometimes we could wait and avoid the risk of ventilator-associated pneumonia and other problems. But we also learned that COVID-19 is not just a lung problem, and multiple organ failure is a major problem. So we had to improve the resuscitation of these patients. Initially, people were focusing on the lungs. They were looking at edema, and they were restricting fluids and giving diuretics to all of these patients. And some patients may have died due to severe hypovolemia with secondary alteration in organ perfusion. I'd love to have my slide again because I want to make sure that I do not forget important points. But this is for the personalization. We could have found better biomarker-guided therapy. Think at immunomodulating therapies. They should be guided by mediators. And finally, prioritization has been a big issue when the ICUs are full, despite the expansion in the number of beds. So there were some ethical aspects which are very important. We had to insist to avoid people applying the first come, first served basis. Something like, oh, what can I do? The ICUs are full. Sorry, I have no room for the next patient. No, we had to go back and reevaluate what we do in patients who are already in the ICU. And so this has been a very difficult challenge, but a very important one to help people to go through this process and not prolonging death by maintaining in the ICU patients who would die regardless of our efforts. So we have learned a lot, and we still have to learn a lot. Hopefully, we will discover other strategies and other pharmacological options because the list is very long of things we can still test.
Each point you mentioned is a whole symposium, is at least a one-day symposium, right?
Maybe 2 days.
So thank you, Professor Vincent, for your thoughtful remarks. It certainly feels like most of the world shares the same challenges with no good solution to some of them. Very sadly, the clock is ticking and we need to wrap this panel up. The good old SWOT analysis tells us there are not only threats, but also opportunities. So it was a great opportunity for me and our audience from around the world to listen and learn from you guys. Thank you, stay safe. And I'm looking forward to meeting you face to face, like we used to, right? Not so long ago. See you, bye.
Thank you, Professor Matota and distinguished guests. As we've just heard, how the crisis often offers opportunities as well as challenges, and the COVID-19 pandemic is no exception to this rule. Since its emergence in China less than a year ago, the virus has affected almost every aspect of healthcare. Many of these changes will stay with us well beyond the pandemic. So the big question is, what would be the normal in the post-corona world? How society and its attitude toward medicine will look like 5 years from now? And what will be the greatest impact of COVID-19 in the long run? We will talk about that in our next session. But just before we introduce our distinguished guests, it's my pleasure to welcome our host, the CEO of ICHILOV Tel-Aviv Sourasky Medical Center, Professor Roni Gamzo, who has served these past critical months as the national coordinator and project leader here in Israel. Roni, shalom.
Shalom.
Professor Gamzo.
Good afternoon.
So before we dive into the pandemic, I just wanted to ask you, how did you manage to do both roles, also run a hospital in these, very challenging times, and also try and run Israel from the pandemic point of view in these very challenging times?
Thank you, Dana. I think the first experience was in the first wave. It was in the beginning of April. The number of cases in ICHILOV, in the Tel-Aviv Medical Center, were not so high, and we were dealing with the pandemic or with the epidemic in Israel, and we were dealing with, in a good situation. And then I feel a little bit bored, and I knew that we have a national challenge. Then I phoned the Director General of the Ministry, and I asked him, please, what can I do for Israel, for you, for the epidemic, for the pandemic in Israel? And then I was recruited within 1 or 2 seconds to run the Father and Mother Shield, which is protecting the nursing home around Israel. This was in the first wave. So I got my experience that I can do both, and I have a good management in the hospital, and I can still help and assist, the entire country on this huge challenge. And I think this is what we, as the leaders of the healthcare system, should do.
Well, I'm sure you're not bored after these 3-4 months that you were doing both jobs. But I mean, when you look at, so you really jumped on the national ship out between the first and the second wave. And here we are after the second wave. Are we facing another wave? Well, what should we do now in order to prevent another wave?
So I believe more or less that we are in the same wave all around the world. So what we are experiencing is when we are relaxing and reopening and we are getting more and more contacts, then the spread of the virus and the wave becomes more and more larger and more challengeable. So in Israel as well, now we are reopening. And once we are reopening, the coefficient of infection or the coefficient that runs the epidemic and makes it more and more dynamic increases. And then we get a so-called third wave. So this is what we are trying to relax and contain, that the number will not increase so much that you will call it a third wave. But we will have some kind of a corona cases number each day that we will have the capability to deal with, and we will not put the healthcare system under strain.
No, it's a world pandemic, but each country has to tackle it in its region. So from the perspective of the Israeli experience, looking outward to Europe, to the United States, what is working for Israel and what is working for other countries? Is there something that you can take from all the countries and try and implement in your geographical territory?
First, Israel is so-called an island. It's not surrounded by neighboring countries that people are going in between. This is what's happening in the world, in Europe. And this is one of the challenges that in Europe, where Europe is facing. So this is one of the advantage of Israel. However, Israel has a kind of a demography that is, very attractive for corona. If you take the number of people in the household in Israel, where you get most of the infection, and Israel is leading the world, the proportion of the youngs where you have more asymptomatic cases, it's another challenge that Israel is facing. So demography base, Israel has a huge challenge. And this is what we are facing. And we have seen that all along the first and the second wave, more pronounced in the second wave, because we had, I would say, the guts to reopen too fast, and the number climbed. And this is what's happening now all around Europe and in the States. So yes, we can learn from other countries, gradual reopening. This is what we are trying to do now.
And let's put the vaccine on the table, because as we speak today, Pfizer has adjusted their prediction and said that they will be 95% efficacy for the vaccine. We have Moderna, and I think we'll hear about more companies in the near future. Can we start speaking about the end of the pandemic?
In my opinion, for sure. I would say that the second half of 2021, we will see the end of this pandemic.
That's very optimistic.
Yeah, that's very optimistic, but this is what I was saying. I have a clear understanding that the vaccine is going to work. This is not only on the theory-based, but really the practical and the technology behind this vaccine is very promising. And you know what? They are preparing themselves to produce billions of vaccines. So I understand that most of the Western world in the second half of 2021 will experience relaxation of the pandemic due to the vaccines that we will see not only from Pfizer and Moderna, but I guess few other pharmaceutical companies.
So you're saying at the second half of 2021, we'll start seeing the post-COVID world. How different will it be from the one that we knew? Let's take it from your hospital perspective.
You know, hospitals will readjust the way that they are providing and operating services. Take, for example, digital services and telemedicine. I believe, truly believe, that the COVID pandemic will motivate all leaders, all hospitals, all healthcare organizations to do more than that. We had a lot of barrier, cultural barrier, physicians that were against that. But during the COVID pandemic, we see more and more relaxation on that issue, and people and physicians, opinion leaders are accepting more that. This is one side. The other side, we will readjust the way that we are prepared. The way we are prepared not only for terror attacks, but also to public health threats. We were not ready for that. Most of hospitals in the world were maybe prepared for all kinds of emergent cases, but not for public health issues. And public health issues and the preparedness of hospital for that will be a dominant part of the preparedness that we will see in the future.
So that's the big question. Because one of the reasons we all were introduced with this lockdown was because we didn't want to, I think, overwhelm the medical system. The medical system post-corona, will it be prepared for another pandemic? Therefore, we wouldn't use this, medieval tool of a lockdown? Or we will, once we face a pandemic, no matter how health system and hospitals are prepared, we'll go back to this tool?
Any smart nation, any smart country in the world will prepare itself in that way, will make the hospital and the healthcare system more adapted to a sudden increase in cases, moderate cases and severe cases. And you know what? Not only hospitals, but technology. We were short in technology. We still are short in technology. In order to lock down the people that are really in a high risk, we locked down the entire country. In order to locate people that were exposed for infection, we locked down the entire country. I'm sure that countries all around the world will be smarter and prepare technologies, will prepare hospitals, will prepare their healthcare system in order not to go through another lockdown in the next pandemic.
Yeah, I think we saw it in Asia, where Taiwan and South Korea, they were more
prepared than us. And the Western world was not prepared. It was not primed as they were primed in the first SARS.
But aren't you afraid that people will forget, politicians will forget, and budgets will go somewhere else, and then we'll have another pandemic and just be back to basic? Because there is the pandemic fatigue that we're all talking about.
There's a pandemic fatigue, but the trauma, the economic trauma, the cultural, the social trauma will make countries, and I was saying smart countries, responsible countries, to learn the lesson and to be more prepared. And I believe Israel will do so as well.
Have you written down notes? Should we wait for your book?
More or less, yes.
What would be the headline?
The Corona SAR or something like that.
Okay, so let's bring into the conversation our distinguished guests that are joining us now. Without further ado, I would like to welcome them to our discussion. Professor Wang will sadly not be joining us due to unexpected circumstances, but we do have with us Professor Michael Binder, Medical Director, Vienna. Michael Binder, Medical Director of Vienna Health Association in Austria, and Professor David Rich, President and Chief Operating Officer, Mount Sinai Hospital in New York. So thank you so much for joining us. And I would like to start with Professor Rich, because I think New York, Professor, was such an astonishing example for the world, because I think it was there where we saw the difference of society entering the hospital and affecting the way that the coronavirus is actually playing out in a territory.
Well, thank you so much for inviting me to join the conference. I'm very honored to be here with you today. One of the things that was very important in April of 2020 was that the health system in New York City was very, very stressed. But we were blessed in that we had a few weeks advance notice, thanks to colleagues in China and Europe who have been publishing and communicating with us about what to expect. And at that time, we were able to draw resources from different parts of the United States. I think the challenge that we're facing now in this very large second wave, which is throughout the United States, is that the very diffuse nature of the disease now in the nation has created a circumstance where hospital staff will be under great stress. We have made some advances, of course, in testing and in therapeutics, but that does not take away the incredible strain on the health system.
That's true, which brings me to Professor Binder. So as Professor Gamzo mentioned, we followed the Austrian model here between the first wave and the second wave. And, you know, the motto was, let's open just responsible as they did in Austria. And here you are also facing a second wave. So what is your take from the fact that even if you open slowly and responsibly, you can't avoid the second wave?
So thank you very much for being here. And I think the opening, if it's really so slowly or it happens so slowly, is a good question. What we are facing at the moment is a second wave, like comparable to Israel. So we are comparable in size. And we managed the first wave very well. And now in the second wave, we do see much more cases, incident cases all over Austria. And very interestingly, it's not just in the metropolitan region of Vienna where I'm sitting at the moment, it's also on the countryside. So most interestingly, country regions do have more incidents currently as metropolitan regions, and we do not have really answers for that. So what I think is that we will not get rid of this virus before an effective vaccine will diminish the effect of the virus. And we have to be very careful right now. And as you know, we are now in a second lockdown. So we also increased or augmented our lockdown now to a so-called sharp lockdowns. First, we had some kind of 2 weeks of soft lockdown, which was not that effective. And I think I'm very sure that this kind of lockdown will work and will reduce the number of incident cases. But in the month of January, February, and further months, we have to be very, very careful that corona will reoccur and also might reoccur in kind of a third or whatever wave. So we have to be substantially careful in taking all these basal precautions, which is distance, which is mask wearing. And as you know or might not know, there was a big discussion in Austria on whether or not masks are useful or not. And obviously those people won in the general perception of the population that masks are not useful. And we also lost our basic sense for precautions. And I think this is a very important problem. And we have to be aware that it just works when we have the population with us and not against us.
Professor Rich, I would like to hear your take on preparing for winter and a third wave. How is that in your hospital?
Well, everyone is quite concerned about what will happen in the next several months as the rates in our region are going up, although much slower than rates elsewhere in the United States. But if you look at the United States as a whole, we're very concerned about what will happen. We have a Thanksgiving holiday next week, and it's very difficult for people to break the traditions of family gatherings, of large gatherings inside. And that's just a week from Thursday. And so what we are always concerned about is that after mass gathering events, that 2 weeks later, we see a rise in hospitalizations, and several weeks after that, we see a rise in deaths. So it's very important that everyone emphasize public health measures. It's delightful to see wonderful results about vaccine capability. It's great that we have an emergency use authorization in the US for bamlanivimab, which is the first monoclonal antibody, although very restricted utilization and very limited dosing available. But that means in the face of slightly improved therapeutics, actually nice improvements in mortality, but still we have a very deadly disease that can only be controlled by public health measures at this time. And so we have to be very strong with the rest of the nation, and frankly, in serving, hopefully, to get that message out to the rest of the world, that public health measures, that the social distancing, masking, and the very painful economic effects of limiting businesses, especially bars and restaurants, are very important so that we don't have excess deaths in the months to come.
I want to ask you, Professor Gamzo, you know, I think from the media point of view, it was such a delight in a way. I don't know if delight is the right word, but it was really inspiring to have all these doctors and professors in the studio, finally, not politicians, but doctors and professors. And of course, they were mainly from the fields of internal medicine and intensive care. So I wanted to hear from you your thoughts about the post-corona world, medical world. How will this affect, or will it have an effect on, you know, specialties and division within the medical profession?
You know, in the Tel-Aviv Medical Center in ICHILOV, we just opened a new department that involves internal medicine and ICU altogether. And we have seen during the pandemic, during the crisis, the joint efforts of two medical teams, the internist, the internal medicine specialists, and the ICU specialists, in a way that it increases the quality of care in the internal medicine department. And I believe that we will devote more resources, more focus, better quality in the way that we give healthcare services within the internal medicine divisions. We will have more ICU beds, more special units within the internal medicine department to give better care, to be more focused, and to maybe we'll have specialists that are internists, but ICU internists within the internal medicine department. And we will enjoy having better care and better services in the internal medicine division because of that.
Do you both professors feel that this is indeed an opportunity to try and change or evolve the relations within the medical field, prestige, specialties, and whatever, and so on?
With Professor Gamzo, it will definitely change our working together in the next years. But I'm also aware of the fact that we will need to care for post-corona patients. So at the moment, we do not know how many patients will get not healthy after their corona episode and will have, for instance, breathing problems and so on, or cardiac problems. And I think we also, and what we are doing at the moment, we are focusing on building a center for the rehab of patients who, for instance, had a successful episode of ICU treatment, but are now in a stage of their rehabilitation or rehabilitation where it's necessary to care for them, let's say in a hospital or in a rehab center. I think we will need more rehab facilities for people, for the many of our citizens who had corona.
Professor Rich,
I think that one of the things I want to emphasize, in addition to what we just heard from Professor Gamzo and Professor Binder, is that we have also established a post-COVID treatment unit. However, the research is very preliminary now. We have a lot of autopsy findings. We have clinical echocardiography findings. We have MRI findings suggesting that there is damage in a subset of patients, especially in heart and brain, and we're also seeing fatigue syndromes. But I want to emphasize one more point, is that there is a mental health crisis which is also brewing throughout the world, because the effects of social isolation, the effects of social distancing are very difficult for some people, and the ensuing economic crisis creates unemployment and additional stress. So working very carefully with our behavioral health professionals, it's extremely important that countries come up with an effective way to prevent an increase in mental health disorders and especially suicides.
Yeah, Professor Rich, that's so true. But I think if we're talking about this conference, Professor Gamzo, it's about sharing information. Yeah. It's about reaching out. It's about understanding that it is a world pandemic and there are world leaders in hospitals that we can share information. What is your vision when you think about sharing the information and working together?
I would say that this pandemic in the issue of sharing was a little bit of a disappointment because we didn't see really international governing association that was leading the pandemic in a way that you could learn from one country to another.
You had the World Health Organization.
Yeah, we had the WHO, this is their role, but we had a lot of in-between experience, many initiatives between friends, colleagues that know from one hospital to another, from one country to another. We had discussions within the WHO Europe. We are in WHO Europe. But mainly what was happening is one physician to another, colleagues on a Zoom, on a telephone call, what you are doing, this is what's happening here, this is what our experience. And we were learning from one day to another from colleagues in between hospitals. This is what happened during this pandemic. We have to find a better communicative tool to do that better in the next pandemic.
Professor Rich, you mentioned that the fact that you had a couple of months or weeks to prepare, you could learn from the experience of your colleagues. How would you want to see it after the post-COVID world? How would you want to try and take it to the next step?
Well, I believe that the key to exchanging information is to ensure that the public health leadership of all nations, including the United States, European health agencies, et cetera, create the forums for sharing information. For example, the CDC in the US with the Morbidity and Mortality Weekly Report, I think is an extremely good forum for doing this. The unique nature of this crisis perhaps did not lead to the best communication in the early phases of this, but we have an opportunity to learn from that and to improve and to continue to share information in an important way. I think the challenge that many of us face is we feel like we're seeing science by press release as opposed to peer review, but we have to balance the needs of disseminating scientific information quickly with the quality of that information if it is rushed into the public sphere without peer review. So it's a delicate balance.
Professor Binder, being in Europe, was it a different experience when it came to sharing information and sharing experience?
Said, but I think it never happened before in history that such a large body of evidence and scientific research has been produced and is also accessible to us by means of electronic communication. So I think this is very important, and also very important and highly interesting is that we could manage to produce at least vaccine candidates, not just one or two, but I think 30 or 40 different companies are now in the race for producing a vaccine in less than a year, in about 9 months. So this is astonishing on the one hand. On the other hand, I do agree that we have or we should enforce our investments in public health in the next years substantially, because we have lost it almost. Yeah? We thought infectious diseases are not interesting, at least in the Western world. And so this is a very important part. And I also think that usage and utilization of all network technologies which is used in computers should be also used, and we should be all enabled to use it. So this is not the case at the moment. And Professor Gamzo is completely right. It was just on his personal intention to contact me, for instance, to contact other doctors all over the world in order to get some more knowledge on how to treat or how to diagnose patients. And this should be coordinated internationally, of course, because it's a pandemic and therefore we need an international coordination. Yes.
Yeah, I want to bring, because our Chinese guests could unfortunately not join us, but I think we have to acknowledge the fact that this indeed has started in China. In a way, how much did it affect the way the world treated the virus and the pandemic? The fact that it started in China and we saw actions taken by a Chinese government that maybe could not have been taken by other governments. Do you how big of an impact is it that it started in China, Roni? Professor Gamzo, sorry.
Assisted at the first place Italy to respond on the lockdown issue. We saw the lockdown in China and we were thinking to ourselves, okay, it can happen only in China. And then when we had that in the north in Italy, it took days, weeks, a week or two after the collapse or during the collapse of the healthcare system in the northern part of Italy to say, okay, they are going into lockdown as well. Wow. So this was primed by China and continue all over Europe, of course, in Israel and in the States as well. And it is a huge, a huge change in the way that you react to epidemic or to a pandemic. And really, it has something to do that it started in China.
Yeah. Well, we're reaching to an end, so I wanted to ask both of you, Professor Binder and Professor Reich, we want to end on an optimistic note. Professor Gamzo said that he believes that we're going to see the end of 2021. Do you agree? And if you can leave us with an optimistic observation from all this.
Please.
Happy to start. I think that the optimism is that therapeutics in the form of antibody therapies, hopefully remdesivir data continue to show great improvement, the use of steroids, and then, of course, the availability of vaccines are all very, very bright things on the horizon. I think to frame it in the positive, but to still state the challenge, the most important thing for all of us to do in medical leadership is to emphasize to the population of the world that the vaccines, when they're produced, are something that is very important for people to take. There will be some people who are afraid of vaccines. There will be some people who refuse on the basis of certain beliefs that need to be, and they need to be educated. So let's take this as a point of inflection where the public health discussion moves from measures to control spread of infection to one where we emphasize that when vaccines are available, that it would be a great tragedy if we do not use them appropriately. But we have that ability to really make a difference and to truly start to get a handle and to start to begin the control of this worldwide pandemic.
That indeed is going to be a challenge. Professor Binder, your closing remarks?
Remarks are quite brief. So I think we should be patient. The vaccine will come, but it will not come too soon. And until we are waiting for the vaccines, it's not just one, we have to be resilient. We have also to use this time frame until a vaccine will become and will be distributed in order to overcome vaccine reluctance among our citizens. So there is a substantial increase in vaccine reluctance in the United States and also in Europe. And so the last point is we also have to improve our public health measures. This will not be the last pandemic. And I think we are quite in a perfect situation right now. In order, we are all very alert that pandemics really occur and just not in the textbooks. So we should address together, physicians and all healthcare workers, our politicians, that it is necessary for the next years to also to invest a substantial amount of money in the infrastructure of public health all over the world.
Professor Gamzo?
Closing remarks. Again, the second half of 2021, we will step out of the corona pandemic. More experience, I would say, more resilient, more prepared. Healthcare system will be much more prepared to maybe another pandemic. And the economy will take a year or two to return, and people will return to their regular social habits of social interaction.
I hope that would be... I'm going to write you and take you for your words. Thank you, Professor Gamso. Thank you, professors, for joining us. I wrote down second half of 2021 for the good news, so that's great. Thank you so much. So thank you again for it was our honor to host you today at the World Leading Hospital First Conference. And now for a different perspective on the new world order after COVID-19 from our special guest this afternoon, the internationally renowned author, journalist, and columnist, and 3 times Pulitzer Prize winner, Mr. Thomas Friedman. Hello, Mr. Friedman. It's so good to have you. Thank you so much for taking the time.
Anna, it's so great to be with you.
So we were talking all afternoon about the COVID-19, the challenges, the post-COVID world. And I think the U.S. has been a test case where COVID met politics and politics met COVID in an unprecedented way.
Well, you know, one of the challenges we've had in America from the very beginning, Dan, is to understand that this is actually a natural systems event, a virus like this. And we had a president who basically had never really encountered a natural systems event. He didn't look at the world through natural systems. He looked at the world through markets. And so if markets were going up, he thought he was winning against the virus, when of course the virus was a completely different phenomena. So let me just say a couple words about that. Viruses are one of the many challenges that Mother Nature throws at her species, plants and animals, to sort out who's the fittest, who shall get their DNA into the next generation. And when Mother Nature throws these viruses at her species, these challenges, and they can be, by the way, droughts, floods, wildfires, hurricanes, tornadoes, you name it, who does she reward, Mother Nature? She doesn't reward the strongest, no. She doesn't reward the smartest, no. She actually only rewards the most adaptive. Who can adapt most quickly to her latest challenge? And when she poses that question to her plant and animal species, she actually asks them 3 things about their adaptation strategy. First is, are you humble? Do you respect my virus? Because if you don't, it will hurt you or someone you love. Second, she asks, are you coordinated in your response to my virus? Because I evolved my virus over millennia to find any crack in your immune system, either your individual immune system or your total societal immune system. And lastly, she asks, have you built your adaptation strategy to my virus on chemistry, biology, and physics? Because that's all I am, says Mother Nature. I'm just chemistry, biology, and physics. You can't talk me up, you can't talk me down. You can't say, Mother Nature, it's Thanksgiving or Passover. Could you take a few weeks off? No, she's going to do whatever chemistry, biology, and physics dictate. And she always bats last, and she always bats 1,000. And so looking at it from an American point of view, and I'll just end here, if you just look at those criteria, we didn't respect the virus. We were not coordinated. We let 50 states do 50 different things. And of course, the virus doesn't know where the border is between Georgia and Florida. And our president did not build his adaptation strategy on chemistry, biology, and physics. He built it on politics, ideology, and an election calendar. So we locked down recklessly, we opened up recklessly, and now we're living with a virus that's out of control. Viruses are also living things just looking for a warm place to call home. And right now they're finding a lot of warm places in different American cities and American citizens.
And I think that's what really surprised the world, because they were looking at the United States and were thinking if there was a place in the planet that could tackle the virus because of, being so adaptive and being so leading and being so, humble in ways throughout history. And then we saw the way it attacked the United States and is leaving with unprecedented numbers. How will that affect the United States standing the day after?
Well, it's a really important question, Dan. If you look at compared to China, which has had about 5,000 deaths, according to their own statistics. Well, let's say they're not telling the truth, double it, triple it, quadruple it. Do whatever you want. It's still a fraction of ours, and they have, almost 4.5 times our population. So, if you just compare it to U.S. and China right now, Danny, you'd say that China is going to come out of the virus, which began in China, with the legitimacy of its regime stronger today than it was a year ago at home, and the legitimacy of its regime internationally stronger today than it was at home. And America, the mother of democracy, just the opposite. The legitimacy of our government has been damaged at home, and it's certainly been damaged globally, because globally, in crises like these, as you implied in your question, America always played three roles historically. We were the leader who came together and organized the global coalition against the crisis, whether it was Nazism or a pathogen, number one. Second, we provided aid and comfort to other countries. And third, we're a source of truth and science. We've played none of those roles. We didn't coordinate anybody. We pulled out of the WHO. We were not a source of truth and science, and we provided no aid and comfort. It just shows you how, under the Trump years, how far off our game we are.
And is it all just because one person? I mean, you're talking about a nation of 350 million people, and what you're, explaining here is just because there was this one person sitting in the White House in this specific time?
Well, one person is a good question. Again, one person can make an enormous difference, no doubt, but there's a deeper structural problem. And that is, in these last 4 or 5 years, it's been a process that's been developing gradually. America has lost its cognitive immunity. We speak of, physical immunity, immunity to disease. Well, there's also something one of my teachers, Marina Gorbis, calls cognitive immunity, our ability to sort out fact from fiction, truth from falsehood. And because of the diffusion of websites, Twitter, Facebook, all these new platforms now. 4 years ago when Trump was elected, our election was threatened by an outside force, the Russians intervening in order to game the system. Now, what's happened 4 years later, it's all emerging from the bottom now. Now everybody's out there sort of generating falsehoods. And now you've got these giant platforms like Twitter and Facebook that then just disperse them, all over the society. And so one result of that is that we've lost our cognitive immunity. There are people out there writing every day that masks don't matter. Masks don't help. When we know scientifically that's absolutely not true. That's the sign of a society that's lost its cognitive immunity. And when you have a president who fans those flames, and that's where Trump comes in and amplifies those falsehoods, you end up losing truth and trust. Well, truth and trust are the two pillars of democracy. Without truth, we can't agree on what path to go down. And without trust, we can't go down that path together. And that's America today.
And yet more than 70 million Americans voted for a president who day by day, scientific proof says that the facts matter and masks matter and that there's a pandemic. It's not some kind of China invention. And yet more than 70 million Americans voted for him.
Yeah, look, we're deeply divided in so many ways now. One way is cultural. There's a lot of Americans who don't like the political correctness they see coming out of the left. There a lot of Americans who just don't like this idea introduced by some on the far left of socialism, of disbanding the police. There's a lot of cultural differences between us. And at the same time, enraging people, dividing people, generating lies that will impact people is now an industry in America. That's the biggest change that's happened in this country in the last 4 or 5 years. It is now a profitable business to enrage and confuse and divide people. And when you have, again, a president amplifying it all, you get the kind of election we have.
So that's what I wanted to ask you. I wanted to ask you, so how are you feeling 2 weeks after election? On the one hand, you see the results and the fact that you can say President-elect Joe Biden, but on the other hand, we see President Trump staying in and saying, well, these elections are rigged, I won. And then I read your article this morning, and it said that you were awed and terrified both at the same time.
Well, I was awed because we had more people vote in this election than any time in our history. So think about that, Dan. More people voted in this election in the middle of a pandemic. Risking their lives. And in our system, it's your friends and neighbors who also go out and run the polling stations and count the votes, risking their lives to vote and to count the votes. That's awesome. It's the greatest American election since 1864 when we had an election in the middle of a civil war. That's awe-inspiring. What is terrifying is that we came so close, I believe, to this being our last election. Because if you look at how
your last elections, you think you were that close to losing democracy?
Yeah. Yeah, yeah. As I said in my column today, you know, I feel like I was watching Lady Liberty cross an intersection on Fifth Avenue in New York, and a bus driven by a drunk driver, a crazy wild drunk driver, ran the red light because this driver doesn't stop at red lights, and he just missed her. He just missed her by 100,000 votes. That's how close we came. Because if you look, Dana, at how Trump and these Republicans are behaving when they lost the election, the Republican Party today is a cult of personality. It is a cult of personality. It's Jim Jones stuff. When you look at how it's behaving today, imagine how it would be behaving if it had won and was locked into power for the next 4 years and could then not have to worry about Trump being reelected. He could take control of the courts, the media, the security services in ways that I believe this place would have looked a lot more, would have looked a lot more like Belarus or Hungary today than the America you knew and loved.
Yeah. I want to go back to the COVID because I remember your 2004 book. You started writing it in 2004, talking about, you know, the flat world and the global world. And I think one thing the pandemic has shown us is that, you know, the first time in ages that the borders were shut and we couldn't feel that the world was out there. We couldn't travel. We couldn't, you know, board a plane. How much of that will remain, or will we go back to a flat world after the pandemic?
Well, you know, I've done so many webinars, you know, since the pandemic set in, and everyone asks, is the world still flat? And I partly have to laugh. I say, well, you know, you're the third webinar I did today. I did one in India, one in China, you know, one in Saudi Arabia, and now I'm doing one in Israel.
And they were all asking the same questions. Oh my God.
Exactly. So like, I mean, here I am talking to more people globally than ever before, and they're all asking me if the world is flat. Yes, it is flatter than ever. In fact, I was struck, Dan, as you were warming up, preparing for the interview here, you were actually clicking your pen. And I was thinking to myself, I'm sitting in Bethesda, Maryland. My friend Dan is in Israel, and I can hear the sound of her pen clicking, okay? That's a flat world, all right? So actually, you know, the reason we're here in this pandemic in many ways is because we've actually been experiencing, as the world has gotten more and more connected, more and more pandemics. So I've actually only been covering pandemics for the last 20 years. The first was a geopolitical pandemic. It was called 9/11. Second was a financial pandemic. It was called 2008. The third is a biological pandemic. It's called COVID-19. And the fourth is a looming pandemic called climate change. And the reason this is happening is two reasons, which I can just go through quickly. The first is we've connected more of the world, more nodes than ever before, and we've greased the connections between those nodes more than ever before. You know, Dan, how many people knew that there were 3,200 flights, direct flights from China to the United States between December 2019 and March 2020? 3,200. Wow. There were 50 direct flights between Wuhan to the United States. Wuhan. How many Americans have even heard of Wuhan? Okay, so we're connecting the world more than ever. We are greasing the flow between those connections, making it faster more than ever. But the dangerous thing we have been doing, and that's why we're having all these pandemics, is we're at the same time, we're removing the buffers inside those systems that actually slowed down the flow, protected us from surges, and stabilized the system. So in the name of efficiency, you know, we pulled out buffers in supply chains, and then we discovered when the pandemic hit that all our medicines came from India via Germany. You know, we pulled out buffers in finance, things like rules against high leverage or blocking transparency. We removed cultural buffers. That's where 9/11 came from. The Arab world tried to purge itself of all foreign influences. And of course, the reason COVID-19 happened was we moved the buffers between urban areas and wilderness areas. The Chinese developed into these wilderness areas. They killed the apex predators in these areas. They left behind only the generalized species of bats, rats, and primates that could live in degraded ecosystems. These bats, rats, and primates co-evolved in the wilderness with their coronaviruses, basically. Then we took them out, hunted them, brought them into wet markets in Guangzhou and Wuhan. One of them bit another mammal, or we bit into them, and suddenly a virus that evolved in the wild spread to humans, and here we are today.
Mr. Friedman, thank you so much for this inspiring talk. And I'm sure we're all waiting for Professor Gamza. I don't know if you heard, he promised us that this is going to be over the second half of 2021. So we're hanging in there, and I hope we'll meet in person very soon. So thank you so much for sharing with us your thoughts. And stay healthy and safe. Thank you.
You too.
So, dear viewers, we thank you for your valuable time in joining us in this conference on a topic that has changed our lives, our way of thinking, and most certainly the way we behave. We hope the conference has provided insight that will assist you in dealing with the situation we are experiencing all over the world. Please stay with us for the post-conference interviews and presentations. Thank you for staying with us for the World Leading Hospitals post-conference. And for the next presentation, I'm honored to introduce once again Professor Jonathan Javid, CEO and founder of NeuroRx. Professor Javid, the floor is yours.
Thank you, Donna. It's great to have a chance to talk a bit about the work we're doing with RLF 100, which is our temporary name until we announce the true product name for Aviptadil, which we're using to treat respiratory failure in patients who have COVID-19. And Aviptadil is a fancy name for a natural hormone that's made in the body called vasoactive intestinal peptide. It's a 28 amino acid hormone. It has no known toxicities, and it's primarily concentrated in the lung. Now, we've known for a long time from in vitro work, that is in test tubes, that this hormone inhibits the replication of the SARS coronavirus in lung cells. It increases production of critical surfactants, and I'll explain what that is. It inhibits inflammation from cytokines, and we've known in the past that case control studies show that people who have higher levels of VIP in their blood have an increased chance of survival. Now, we've been doing prospective studies that have shown a very substantial improvement in survival on hazard ratio, improved recovery from respiratory failure, a substantial difference in what's called the ordinal scale. That's the scale by which doctors rate how sick somebody is with COVID-19. And a fourfold improvement in blood oxygenation. So right now, in addition to the FDA phase 3 data we're generating, that is a randomized control trial, we also have an expanded access protocol that's active in the US and also in Israel for patients who have severe COVID-19, critical COVID-19, with respiratory failure. And those patients are getting 3 infusions of RLF 100 over the course of 3 days. And I'm here to tell you a bit about what we're seeing. So let's go back to the history. This is certainly not a new molecule. It's a molecule that's been around for 65 million years, but it was discovered by Professor Sami Said, who was born in Egypt, traveled to the United States as a young physician, trained at Johns Hopkins, and in 1970, he took a sabbatical and went to the Karolinska Institute in Sweden in order to try to discover why patients who have blood clots in their lungs, that's pulmonary embolus is the word doctors like to use, why patients who have blood clots in their lungs have sudden, often fatal reductions in their blood pressure. And he had the idea that some sort of hormone was being released in the lung that would cause this reduction. So he went off to the Karolinska Institute in Stockholm in order to try to make the discovery. And he started out looking for the hormone in animal lungs, but he literally couldn't buy enough kilograms of animal lungs from local slaughterhouses to isolate the peptide, but he could buy very large quantities of animal intestines. So that's how he isolated the peptide. He wanted to name it very important peptide because he realized how important it would be to biology. but the editors of the journal Nature wouldn't let him do that, so he named it vasoactive intestinal peptide, even though it mostly works in the lung. And over the next 50 years, he and others wrote more than 500 scientific publications showing the role of VIP in protecting the lung against all sorts of injuries. It's the reason you can inhale smoke and the lung can repair itself. It's the reason people occasionally inhale stomach contents and the lung can repair itself. Now, his final study, before he retired from Stony Brook University, together with Dr. George Yusuf, who's now our colleague in Houston Methodist Hospital, was to see if he could protect patients who were suffering from acute respiratory distress syndrome caused by bacterial sepsis with VIP. And he got permission to treat 8 patients at Stony Brook Hospital. These were people who were dying of what's called ARDS, acute respiratory distress syndrome, in the ICU, on ventilators, and all 8 patients showed some degree of improvement in their blood oxygen. 7 of those patients were successfully discharged alive from the ICU, and 6 of them walked out of the hospital alive on their own 2 legs. Unfortunately, one had a heart attack about a month after leaving the ICU and didn't leave the hospital. Now, Sammy retired the next year, and the work was taken over by a major pharmaceutical company that stopped working in the area of acute respiratory distress and started working in the area of chronic disease. So really, the invention sat from 2005 until March of this year, when my colleague Yves Segot at Relief Therapeutics realized that perhaps the same effects that were seen in acute respiratory distress syndrome might be beneficial for people with COVID-19. And so far, that hypothesis has turned out to have a great deal of promise. And you've probably seen in the press that we've reported very encouraging early results from what happens when we treat people with critical COVID-19 and respiratory failure with Vivitidol. So in order to understand what's going on, you need to understand something about the anatomy and the biology of the lung. And for this, I really have to thank Professor Robert Mason at the National Jewish Hospital in Denver, Colorado, because he's probably contributed the most in the understanding of the anatomy of the lung, and especially the alveolar type 2 cell, which is critical to the whole COVID-19 story. So let's start out with fish, because fish have a very simple way of getting oxygen out of their environment and into their blood. They swim through the water flows across their gills, and as the water flows across their gills, the oxygen from the seawater goes into the bloodstream of the fish. It gives the fish the energy it needs to swim, and everybody's happy except for the smaller fish that the fish eats. The problem is, as human beings emerged, or as mammals emerged from the oceans and began to breathe air on land, we had a problem. And the problem is that thing that we call the atmosphere is actually a mixture of gases that are quite toxic to the lining of the gill, the lining of the respiratory epithelium. Everybody knows what happens if you take a fish out of water and put it on land. Contact with the air, even though there's much more oxygen in the air than there is in seawater, is toxic to those cells, and the fish suffocates. So how did evolution take care of this? Well, we actually bring just a little bit of the ocean onto the land with us. Instead of the gills sticking out into the ocean environment, we have these air sacs in the lung called alveoli. And those alveoli have little bubbles of essentially salt water that line them. And because the alveoli are lined with this salt-rich mixture, this saline mixture, they're able to withstand the toxic effects of the air. And all of that works just fine as long as you can maintain that what's called surfactant layer in the lung. You essentially have a little soap bubble inside each of those air sacs that first of all holds the air sac open, and second of all allows oxygen to go across the surfactant layer, across the lung cells and into the blood, all without harming the delicate cells of the lung. And all of this happens because of that one cell you see, the type 2 cell, that makes all of the surfactant. So even though the type 2 cell is a very rare cell in the lung, without it, the lung can't function. And that's what happens, that's what's attacked in COVID-19. In COVID-19, the spike protein of the coronavirus binds to that type 2 cell in the lung. It enters the type 2 cell, it shuts down production of surfactant, it increases inflammatory cytokines to form, it makes many copies of itself, and it kills the cell, releasing all of those viral particles. That's what kills people in COVID-19, because suddenly the lung is unable to transmit oxygen to the blood. Well, the way aviptidil, vasoactive intestinal peptide, works is it uniquely binds to the type 2 cell in the lung. There's a special receptor on the type 2 cell that binds to VIP, and VIP enters the cell. It blocks the production of virus particles. It blocks the production of inflammatory cytokines. It increases the surfactant, and all of a sudden the lung is able to survive the onslaught of the coronavirus. You can see this in a test tube where when you add VIP to the test tube, it blocks the replication of the coronavirus by half. It blocks the ability of the coronavirus to kill the cell by 40%. So you can see it in test tubes and you can see it in people. The other interesting thing you can see in people is that if you look at people who get critical COVID-19 and look at the difference in the level of VIP in the blood of survivors versus those who die of critical COVID-19, the survivors have twice the amount of natural VIP in their bloodstream compared to the people who die. So we went into the clinic, we went into our clinical trials believing that we had a synthetic human hormone that blocks the replication of the coronavirus in the alveolar type 2 cells of the lung, that blocks cytokine production, that blocks cell death, and that increases surfactant production, increases the ability of the type 2 cell to make the surfactant lining that's critical to the ability of the lung to function. And we licensed this technology from Stony Brook University. They were excited to show us that Sami Saeed's file cabinet was still sitting in the corner of his laboratory just as he left it 10 years ago. We came into the picture with extensive toxicology data from 4 species showing that VIP is non-toxic even when it's used over 6 months or more. And a cooperative agreement with the National Institutes of Health to test VIP against influenza and other viruses beyond COVID-19. So our path is twofold. First of all, we're at the latest stage of testing VIP in patients with critical COVID-19. Those are people who are in the ICU, they're either on a ventilator or they're getting high-flow oxygen, and they're being treated with intravenous VIP. And now we're starting a second study to use inhaled aviptidil in patients who have earlier stages of COVID in the hopes that we'll keep them out of the ICU. Now, we have one study that's already showing data that we've reported. This is not our randomized prospective trial. This is a study that our colleague, Dr. Yusuf at Houston Methodist Hospital, did in 21 patients who were too sick to get into our trial. Patients who had lung transplants, kidney transplants, immunosuppression from cancer, recent heart attacks, people who couldn't be randomized in our FDA phase 3 study, and he compared them to equally sick patients who weren't getting our drug. And he showed that they were comparable at the beginning on all of the scales that people use to grade severity in patients like this, scales like the Rothman Index, the Organ System Failure Score, the WHO Ordinal Scale. So we started out with 2 groups of patients who were quite comparable in everything, and they were in the same ICU, being treated by the same doctors, the same nurses, according to the same protocol. The only difference is that the 21 patients got RLF 100 and the 24 patients just got the standard of care. And some very striking differences were seen. So as you can see from this survival curve, the primary endpoint in this study was whether people survived critical COVID-19. And the blue line are the patients who were treated with RLF 100 plus the standard of care. And over 60 days, they had better than an 80% chance of leaving the intensive care unit alive. Whereas the red line are the people who just got the standard of care, and over the same 60 days, from the same ICU with the same doctors and nurses, they had less than a 20% chance of leaving the ICU alive. Overall, what statisticians call the hazard ratio was 9-fold difference. Similarly, you can look at the likelihood that people recovered from respiratory failure. Here, higher is better, and the blue line shows that at 60 days, people with critical COVID-19 had a 60% chance of being off the ventilator or off of high-flow oxygen. In other words, they had recovered from respiratory failure, whereas the people who just got the standard of care only had about a 10% chance of recovery. And again, the hazard ratio was about 9-fold difference. You can also see it if you look at what's called the WHO Ordinal Scale, and this is the official scale by which people who have COVID are graded on their recovery. And there was a 6-point difference because the RLF 100 treated patients got several points better, and the standard of care patients got several points worse. You can also see the difference in blood oxygenation. So here, higher is better. And you can see that the people who got treated with RLF 100 showed dramatic improvement in blood oxygen even within 48 hours of starting treatment, whereas the people who were treated just with the standard of care showed very little change in blood oxygenation from the time they were entered into the study. And finally, you can see a difference on chest X-ray. This is one of many patients, and if you're not a radiologist, the thing to know about chest X-rays in COVID-19 or any disease is, in general, white is bad and black is good, because the lung is mostly made of air. There's very limited solid material in the lung to block the X-ray. So a healthy lung is primarily black, but you can see that these patients with COVID-19 have a practically white lung because the alveoli have collapsed, there's inflammatory debris, and yet within 2-3 days of treatment, you start to see clearing of the lungs in a substantial number of patients. In fact, this kind of clearing was seen in 17 out of 21 patients in both lungs, and in 2 additional patients in 1 lung in the people who were treated with VIP. And it was seen in far fewer patients who were treated just with the standard of care. So you've got improvement in survival, you've got improvement in recovery from respiratory failure, you've got improvement in blood oxygenation, and you can see it on X-ray. You can also see a substantial decrease in the inflammatory markers as they're measured in a hospital laboratory, what they call the cytokines, which are these inflammatory molecules that are believed to cause damage in COVID-19. So we're heading for the tail end of a randomized controlled trial that's already enrolled 150 and is going to enroll more than 165 patients with critical COVID-19 and respiratory failure who are being treated with intravenous RLF 100. And now we're starting a trial of inhaled Aviptidil for patients with early COVID-19 in the hopes of keeping those people from developing respiratory failure. The FDA has granted us an IND. We're expecting Dr. Youssef to lead the study for us again, and we're extraordinarily excited to get started. So in summary, RLF 100 has been around for a long time because vasoactive intestinal peptide has been protecting the lungs of air-breathing mammals for as long as there have been air-breathing mammals. In the laboratory, we see that this substance, VIP, inhibits the formation of the virus in lung cells. We see that patients who have higher levels of natural VIP in their blood are more likely to survive. And we see in prospective trials that treating patients with VIP is associated with a very substantial difference in survival and a substantial difference in recovery from respiratory failure. So Donna, thank you for asking me to share this with your audience.
Thank you, Professor Javid, for your presentation. There's so many follow-up questions. I just want to make sure and recap, if you could, what is the RLF 100?
So RLF 100 is our working name for Aviptidil. And Aviptidil is synthetic VIP, or vasoactive intestinal peptide. The only difference between Aviptidil and VIP is Aviptidil is made in a factory, VIP is made in your body, but it's the same 28 amino acid peptide.
Now, there seems to be so many experimental treatments for COVID-19. Each has its own proponents. To paraphrase a famous saying, what is special? Why is your medicine or this medicine different from all the other medicines?
Well, there are several broad categories of medications that are used to treat COVID-19. One are the antivirals like remdesivir that are designed to kill the coronavirus. And then you have this whole category of anti-inflammatory medicines that in one way or another try to mop up the inflammatory cytokines that are associated with the viral infection. And none of them has worked very well. Our medicine, and it's really not our medicine, it's invented through nature and naturally synthesized in the body already, is a peptide hormone that enables the lining of the lung, enables the pulmonary epithelial cells to resist the virus. And it's actually been around in nature for as long as air-breathing mammals have been breathing air.
Now, when you say peptide, the word is a bit confusing. Can you elaborate?
Sure. Amino acids are the building blocks of the body. Proteins are made of amino acids. And peptides are very short proteins. Okay. It sounds like an unfamiliar word, but everybody's familiar with insulin. Insulin is simply a peptide that regulates blood sugar. Growth hormone is a peptide that enables the body to actually grow. And in this case, VIP is a peptide that protects the type 2 cell that lines the lung and is essential to the lung's ability to transmit oxygen to the blood.
And, you know, before COVID, I think we never used the words respiratory distress as much as we do today. Is it just a fancy word for, you know, not being able to breathe?
Well, a lot of people think that, and it's absolutely untrue. So there are two parts to our ability to use air. One is our ability to move air in and out of the lung. Some people call that the ability to ventilate the lung, inhale and exhale. Respiration, the respiratory unit of the lung, is the ability of the lung to take oxygen from the air and bring it into the bloodstream. Now, I'm sure there are lung specialists in the audience who will tell me that I just mangled that because I'm a dumb ophthalmologist. But if I'm explaining this to the average person at the dinner table, that's how I would explain it. The lung has to be able to move air, to move oxygen out of the atmospheric air and into the bloodstream. And when the lung can't do that, that's respiratory failure.
And you're saying that the COVID does its lethal damage by attacking just that kind of cell in the body?
Well, COVID is even more specific than that. So the SARS coronavirus infects just about every mammal around. But the only mammal that seems to get COVID-19 disease and die of respiratory failure is the human being. People have talked about, unfortunately so. People have talked about bats and pangolins, but you don't see dead bats everywhere. Unfortunately, we're seeing a lot of dead people. And what's happening is the virus is able to attack this very specialized cell in the lung, the type 2 cell, that makes the surfactant layer that lines the lung. So in order to understand what's going on, you kind of have to start out with fish.
Okay.
Fish swim through the sea, and they don't really have any issues breathing. The seawater goes across their gills, the oxygen comes out of the seawater, it goes into the fish's blood, and the fish is able to swim around and eat other fish. That's what fish do for a living. The problem is if you take a fish out of the sea, where there's relatively little oxygen in the water, and put it onto the land where there's all the oxygen you could ever want in the air, the fish dies very quickly. And it dies because that mixture of gases that we call the atmosphere is toxic to the cells that cover the gills of the fish.
It's too much. It's too much for
Well,
them.
it's not only too much, but imagine everybody knows what happens if your eye dries out. You get dry eye, then you get a sore eye because you've had a couple of the corneal epithelial cells die from contact with air because the tears didn't cover the front of the eye. Well, in the same way, if you lose the liquid lining that covers the inside of the lung can't function. So fish have no way to replenish that liquid lining if they're out of the water, and they die very quickly. As humans emerged from the sea, or as mammals emerged from the sea, they brought a little bit of the sea with them. What happened is the air sacs in the lung are lined with salt water. But you can't just put water on cells and hope it's going to stay there. You need some sort of detergent or surfactant that's going to let the water spread out. If I put water on this table, it would bead up and roll off. If I put the tiniest bit of dish soap on that drop of water, it would spread out and cover the whole table. So these type 2 cells in the lung, they make that surfactant. And they make, even though they're only 5% of the cells in the lung, they're able to make enough surfactant to coat the whole lung. And that's how the air sacs of the lungs stay open, and it's how air is able to transmit oxygen into the blood without damaging the cells of the lung at the same time.
Okay, so let's go back to the medicine. We're talking about the RLF 100. What are the results so far?
Well, first let's talk for a second about what the medicine does.
Okay.
And what the medicine does is specifically binds to that type 2 cell in the lung. Doesn't bind anywhere else in the lung. It just targets that cell. And when it goes into that cell, it kills the coronavirus. It stops the virus's ability to divide and replicate.
We're seeing now the VTR.
Yeah.
This video, yeah.
So I brought you a picture. So the coronavirus isn't too much trouble to people. It doesn't make you very sick until it gets down into the lung. And when it gets into the lung, it goes straight to that type 2 cell that's lining the lung, that's protecting the lining of the lung, and the spike of that virus binds to a specific receptor on that type 2 cell. And it enters the cell, it blocks the ability of the cell to make surfactant, it increases the inflammation that's produced by the virus. The inflammation ultimately overwhelms the cell itself, and the surfactant layer of the lung is damaged. Of course, at that point, the virus lets loose and infects all the other cells. And VIP comes along, it binds to the same cell, and it blocks the virus's ability to replicate. It increases production of surfactant. It blocks those inflammatory cytokines. If you were to talk to a human drug developer and say, design me a molecule that does all these four things, the drug developer would say, you're crazy, it can't be done. And yet that's exactly what nature has invented over the course of 65 million years of evolution.
Yeah, thank God we've got Mother Nature. So what are the results so far?
Well, so far, we've seen that in an open label study, because our phase 3 study is still ongoing and we don't know the final results, but in an open label study, we've seen a 9-fold advantage in survival among patients who were too sick to get into our randomized phase 3 study, and a similar advantage in terms of recovery from respiratory failure, that is, getting out of the ICU and going home to your family.
And you mentioned that your FDA trial is still blinded, so you don't know the results. But there are Houston results being seen anywhere else?
So at this point, close to 150 people have been treated under expanded access in the United States, in Israel. We've even treated a few patients in Mexico. And on a regular basis, doctors are sending us x-rays, and I think I brought one of them for you, showing very dramatic recovery from the signs of COVID-19. Here it is. You can see that before the patient got the investigational drug, the lung was full of white stuff. And that white stuff is collapsed air sacs, collapsed alveoli. It's very characteristic of COVID-19. They call it ground glass appearance. And within 48 to 96 hours, that lung had improved very substantially, and that patient went home.
That's really interesting. It sounds like a human, natural iron dome inside your lung.
But there's a reason for that, because the lung needs an ability to repair itself.
Of course.
So this peptide wasn't invented because of COVID-19. This peptide was invented because animals wind up in forest fires, and they need some ability to repair the lung from smoke damage. Occasionally, animals inhale toxic things, such as stomach acid, and the lung needs an ability to repair itself. This peptide is critical to natural repair of the lung.
Interesting. Now, you played leadership roles in 7, right? 7 successful healthcare, IT, and biopharma startups with public exits. That's quite a record, I must say. And, you know, we're living in these very different times of COVID-19, and I was wondering what has changed in terms of the policy, the regulatory policy, and the process of, you know, approving treatments?
Well, at least in the United States, the FDA has tried to really change its ways, change itself into a much more nimble organization. They established the Coronavirus Treatment Acceleration Program, and I haven't seen the FDA become easier on the rules, but I've seen them become much quicker on the rules. So a meeting that used to take 90 days to get can now be had in 9 days. They're still going to be tough on you, but they're going to do it a lot faster.
And is there no danger in the fact that they're doing it faster and less tougher?
Well, I didn't say they were doing it less tough.
Okay. I
said they were doing it faster.
So they could have done it faster before, or this is a conceptual change that will stay on after COVID, or they'll go back to their own pace?
I'm getting emails from FDA scientists at 2 in the morning. I've never heard of a government scientist sending emails at 2 in the morning before. I think everybody's pretty focused on trying to not lose a 2 million people from this terrible disease.
And what will stay with us post-COVID?
Well, that's going to be an interesting question. I think there will be far fewer in-person meetings at FDA. I'm not sure, you know, it used to be that you'd fly 9 people to Beltsville, Maryland, and put them in a Holiday Inn for a 1-hour face-to-face meeting. And people are figuring out that there's an awful lot you can do remotely. I think data exchange will continue to be faster. hopefully people won't continue to be sending emails at 2 in the morning because you can only sustain that for so long.
For so long, yeah. Yeah. Well, just before we close, is there anything that you would like to finish off with, leave us with these remarks?
Well, you tell me. We're sitting here in Israel, and Israel's a country that's always followed the FDA. How do we get Israel to take the lead? How do we get Israel to start approving drugs here as a first place in the world to approve a drug instead of following the FDA?
What is your thought on that?
I think Israel needs an FDA.
An FDA, but yeah, that's an idea, but that it wouldn't be the American FDA, it would be the Israeli FDA.
That's right. Well, there's the Chinese FDA, there's the US FDA.
That's a challenge for all of us. Yeah,
yes.
That's really a thought that we should take in consideration. Professor Javid, thank you so much for being with us and sharing with us your presentation and your information. And good luck.
Thank you.
Thank you, Professor Javid. And now for a closing presentation, please welcome Dr. Luba Tau, Infectious Diseases Specialist, Infectious Diseases Unit at Tel-Aviv Sourasky Medical Center.
Thank you, Dana. Dear audience, thank you for the opportunity to share the data from remdesivir clinical trials with you. So last week was very exciting for us with promising news coming from Pfizer trial of vaccine showing high efficacy of 2 doses of vaccine. And this week continued to be very exciting for us also with the Moderna announcement of the efficacy of their vaccine with 90 and 94% efficacy. It's really exciting, really promising. So maybe we can see the light in the end of the tunnel. Probably yes. But meanwhile, effective and safe treatment for those patients who are already infected or will be infected with COVID-19 are urgently needed. What we have learned from this really endless corona period is that for each supporting trial, there is another or sometimes more than one trials that are disappointing, and that there is a real flooding of the clinical trials and the results should be interpreted with caution. So let us have an overview on the remdesivir clinical trials, on the major of them, and try to answer the question, to remdesivir or not to remdesivir? We'll have a look on mechanism of action of remdesivir, on main clinical trials, some future trials, and have some conclusions. So, who is the enemy? SARS-CoV-2 is a single-stranded positive sense enveloped RNA virus belonging to beta coronavirus family postulated to be originated from bats. And remdesivir is a prodrug of a nucleoside analog that inhibits viral RNA-dependent RNA polymerase with a broad-spectrum antiviral activity observed in vitro against members of several viral families, including filoviruses like Ebola, for example, and coronaviruses, including SARS-CoV-2 and MERS-CoV. Remdesivir is a prodrug, and intracellularly it undergoes rapid conversion to the pharmacologically active nucleoside triphosphate, remdesivir triphosphate, which is efficiently incorporated into the nascent RNA chain by viral RNA-dependent RNA polymerase, resulting in delayed RNA chain termination during viral replication. And that's its mechanism of action. In vitro, it showed activity against an array of RNA viruses, including filoviridae, paramyxoviridae, pneumoviridae, and coronaviridae. It must be given intravenously. It's the only way to give it now, with a loading dosage of 200 milligrams and maintenance dose of 100 milligrams thereafter. There is a trial of inhaled solution of remdesivir, and it's now under current investigation. We'll see the trials later. Remdesivir is not suitable for oral administration due to almost complete first-pass metabolism. The main routes of elimination are renal and biliary. So let us have an overview of major remdesivir studies for the treatment of patients of COVID-19. The biggest trial, which was NIH and NIAID trial called ACTT1, probably the most important trial of remdesivir, which was a placebo-controlled trial, and patients that were included in this trial were of various clinical status with moderate, severe, and critical disease. The other trial asked the question whether a shorter-term course of remdesivir is as effective as a longer-term. Another trial compared remdesivir to a real-world retrospective cohort of standard of care. also in severe patients with COVID-19. Another trial compared remdesivir to the cohort of patients with moderate disease. And we should not forget also the early Chinese trial on patients with severe disease, and have some words on the Solidarity trial, which is not yet published and available only in preprint version, but worth to have some words about that. So let us start with the biggest one, a trial that was, the final report was published recently in the New England Journal of Medicine, remdesivir for the treatment of COVID-19 patients. And it was Phase 3 adaptive randomized double-blind placebo-controlled multicenter global trial where the patients were randomly assigned to receive either remdesivir for 10 days or placebo, with the primary outcome was time to recovery, meaning the recovery was defined as the worst day during the 28-day period the patients met the criteria of 1, 2, or 3 on the ordinal scale shown on the slide. The patients that were included were the patients with confirmed SARS-CoV-2 infection, and the spectrum of the disease could be from moderate to critical disease, with exclusion criteria that are usual for the remdesivir trials: patients who had elevated transaminases, patients who had declined GFR, and breastfeeding and pregnant women. Okay, so let us have a look on the baseline characteristic of those patients. We can see that they were very well balanced, with a mean age of 59, and 64% were male patients. The majority of patients had one or more comorbidities, with most common of them being obesity, diabetes, and hypertension. The mean duration of symptoms before enrollment was 9 in both groups. It was similar, okay, very important. And the 90% of the patients were in the category of severe COVID-19, meaning having a saturation less than 94% in room air or requiring supplemental oxygen, and having pulmonary infiltrates on chest X-ray. Let us have look on the primary endpoint, the median time to recovery. We can see that patients in the remdesivir group had a faster time to recovery with 10 days versus 15 in placebo control, and it was significantly different. When we have a look on the subpopulations, we can see that remdesivir performed better in those who were on the baseline score of 5, meaning those who needed supplemental oxygen but a low flow oxygen. And it helped less, or even didn't help, for those who were on mechanical ventilation and ECMO. Probably because of those patients who were in the immune phase of the disease, and remdesivir couldn't do much about those patients. Okay? And we can also know from the study that those patients who received remdesivir earlier in the course of the disease performed better. As for the secondary endpoint, which was the clinical status on day 15, we can see that remdesivir produced 50% increased rate of clinical improvement by day 15 on the ordinal scale compared to placebo, which continued through day 29. What about the mortality? The mortality on day 15 was 6.7% in remdesivir group versus 11.9% in placebo group, and on day 29, 11.4% in remdesivir group versus 15.2% in placebo group. Okay, and when we look in the subgroups to understand if there is some group that performed better with remdesivir, we can also see that the group with a baseline score of 5 against those who need supplemental oxygen but not high flow oxygen, the hazard rates of death was 0.3, meaning that remdesivir was associated with 70% significant reduction in mortality in those patients. Okay? And as for the side effects, we can see that side effects were low. Severe adverse events were lower in remdesivir-treated patients, 25%, compared to placebo group with 32%. There were no major differences between grade 3 or 4 adverse events, meaning that remdesivir therapy was safe. Okay? After the preliminary results of the trial, FDA issued the emergent authorization to use remdesivir in patients, hospitalized patients with COVID-19, and EMA afterwards also gave the same authorization for those patients who were hospitalized and required supplemental oxygen in Europe. Let us ask another question. The remdesivir in a short supply, and the pandemic is ongoing. So maybe we can give remdesivir for the shorter duration. And there was another trial, also published in New England Journal of Medicine, which compared remdesivir for 5 days versus 10 days in patients with severe COVID-19. Let's have a look on that study. Okay, it's again randomized, open-label, multi-center international trial with patients randomly assigned to receive 10 days of remdesivir versus 5 days of remdesivir, with primary endpoint was clinical status assessed by 7-point ordinal scale on day 14. We can see that inclusion criteria were patients with severe disease, meaning that the saturation should be less than 94% while breathing ambient air, and pulmonary infiltrates or chest X-ray. And those patients who required mechanical ventilation or ECMO were excluded. Those patients who required it on enrollment, on screening. Okay? When we see the baseline characteristics, we can see again that they are well balanced. Those patients who were in remdesivir group, the median duration of symptoms before the enrollment was 8 versus 9 in 10 days group, a little bit smaller. We can see that on baseline, patients who were randomly assigned to 10-day group had a worse baseline clinical status. They deteriorated during a few days during the period after the enrollment. So we can see that in this group on baseline, there were patients requiring high flow oxygen, or even those who were mechanically ventilated. So let us have a look on the primary endpoint. The clinical status at day 14 were quite similar. The time to clinical improvement was observed in 64% of patients in 5-day group versus 54% in 10-day groups, and the clinical recovery was the same. The mortality was 8 in patients with the 5-day groups versus 11 in the 10 days group. There was no significant difference, and the clinical status distribution didn't change when it was adjusted to the baseline clinical status. Do you remember that we told that in the baseline they were different? So actually, we can say that from clinical endpoint, there were no major differences between 5-day scores and 10-day scores. And as for the side effects, there were, again, no major differences between the shorter duration and the longer duration, with nausea, acute respiratory failure, ALT increase, and constipation being the most common reported adverse events. Okay? So we can say that the 5-day scores of remdesivir performed as well as the 10-day scores, which is fine. Another trial that was published in CID examined remdesivir for severe coronavirus disease and compared it to cohorts receiving standard of care. There actually were two phase 3 trials. That was the data from phase 3 trial and a retrospective cohort of patients receiving the standard of care, with 312 patients in the remdesivir group and 818 patients in the standard cohort. And the patients had to have confirmed SARS-CoV-2 and fall into the category of the severe disease. And the stabilized inverse probability of treatment weighted multivariable logistic regression was used to estimate the treatment effect of remdesivir versus standard of care. The primary endpoint was the recovery on day 14, again based on 7-point ordinal scale. And the secondary endpoint was mortality and clinical improvement at day 14. The baseline characteristics were well balanced. The only thing was that the patients in the standard of care group were more likely to receive hydroxychloroquine as a treatment. Okay? So let us have a look on the results, and we look on the clinical recovery. We can see that 74.4% in remdesivir group versus 59% in a standard of care group recovered by day 14 with the adjusted odds ratio of 2. And as for the mortality rate, we can see again significant difference between the groups, with 7.6% in the remdesivir group and 12.5% in the standard of care cohort. That meaning remdesivir was associated with significantly improved recovery and 62% reduced odds of death compared to a retrospective cohort. This is a little bit different trial. This is a trial in patients with moderate COVID-19. The previous studies were looking on, examined it on the severe disease. again, randomized, open-label, multi-center trial in countries with high prevalence of COVID-19, with patients randomly assigned in 1:2, 1:1 ratio to receive either remdesivir for 10 days, or for 5 days, or for standard of care. Primary endpoint was clinical status assessed by 7-point scale on day 11. As for the baseline characteristic, they were quite well balanced. The mean time from the beginning of the symptoms to enrollment was 8 in the remdesivir group and 9 in standard of care group. There were little bit baseline instabilities in the meaning that the patients on standard of care were more likely to receive treatment that was probably effective against COVID-19, like hydroxychloroquine and so lopinavir, so on. Now we know it's not active, but it was that time. The clinical status on day 1, what happened in the 5 days group, patients in the remdesivir group had statistically significant higher odds of better clinical status distribution versus standard of care on day 11. It's for the 5-day group. But the difference was of uncertain clinical importance. And what happened in the 8-day group? The difference was not statistically significant. So what does it mean? That 5 days is better than standard of care and 10 days is not better than standard of care? It's a little bit strange. And what we also seen in this trial, that the peaks in discharge rates were observed in remdesivir groups. It was an open-label trial, and the doctors just wanted to let the patients to receive the full course of remdesivir. And what we saw that the peaks of discharge were on day 6 in the 5-day group and on day 11 in the 10-day group. Well, it's an open-label trial design, so probably because of that. What about the safety and tolerability? Any adverse events were observed in 51 or 59% in patients in the remdesivir group and 47 in a placebo. More common adverse events were nausea, diarrhea, headache, and hypokalemia. Grade 3 or 4 ALT increase, grade 3 or 4 creatinine clearance decrease were less common in the remdesivir group, so remdesivir was quite safe and tolerated well. Let us now have a look on the first trial of remdesivir, which was published in April, and the trial that came from China. It was a trial, again, in patients with severe COVID-19. It was investigator-initiated, randomized, double-blind, placebo-controlled, multi-center trial in Wuhan. There were 10 hospitals that were participating in this trial. The inclusion criteria were patients with severe disease, with a symptoms duration of less than 12 days. With the primary endpoint was time to clinical improvement by day 82. It was planned to enroll 453 patients, but what happened, in fact, that there was a successful outbreak control in Wuhan in the middle of the study, and they actually were able to enroll 237 patients, and it, of course, made a problem with the study power, and it had an influence. The randomization was 2:1, so 158 patients started to receive remdesivir and 78 received the placebo. There were some baseline imbalances with patients that were more having comorbidities were included in the remdesivir group, and patients that had shorter duration of symptoms before the randomization were included in placebo group, the things that could influence the outcomes of the study. But the bottom line, remdesivir didn't work well. There was no statistically significant difference in the time to clinical recovery between groups. There was a numerical, but not statistically significant, benefit toward remdesivir group in those patients who received the treatment earlier in the course of disease, less than 10 days. But from the other hand, the virological characteristics that were also performed in the study didn't show major difference between the groups, and it is often concerned. As for the adverse events really didn't differ between the groups. Of course, there are limitations of the study, and the biggest one, the early termination, the reduced enrollment from 453 to 236, reduced statistical power from 80% to 58, and it's important, and there were possible baseline imbalances. But still, it's worrisome. And now have a few words, not more than few words, because it's still in preprint and not published, on Solidarity trial. We know that it's a large multi-country open-label adaptive randomized trial of WHO without placebo control, with the drugs of possible antiviral effect on COVID-19 being studied there, including remdesivir, with the primary outcome was in-hospital mortality and secondary outcomes of initiation of ventilation or hospitalization duration. With the remdesivir was administered for 10 days in this study. The death rate ratio for remdesivir was 0.95, and actually no study drug definitely reduced mortality, initiation of ventilation or hospitalization duration. Well, it's disappointing. We don't know all the facts about the study. We don't know whether on what day the remdesivir was administered, whether it was administered late in the study course, in the course of the disease, or maybe earlier. So we need to see more data, and we need to see the study published. But still, we know that it is here, and it's also of a concern when we decide how to treat. There are some future trials. There are some combination trials with remdesivir with baricitinib, then remdesivir with intravenous hyperimmune IVIG, monoclonal antibodies, and other trials. There is an outpatient remdesivir IV study with remdesivir being assigned for 3 days for patients who are in high risk for disease progression, like those above age of 60 and those having comorbidities. There is a caravan study, which is a study in pediatric population, and then finally a study of inhaled solution of remdesivir being given in patients with early COVID-19. It will be very interesting to see the results of those studies. So let us come back to the question we asked in the beginning, to remdesivir or not to remdesivir? Well, it's complicated. We can see that there are more trials in favor of remdesivir. A CTT1 trial, the trial versus standard of care cohort, some benefit in patients with moderate disease. But from the other hand, there is a Chinese trial and the Solidarity trial that doesn't favor the use of remdesivir. Well, corona is corona. Everything is complicated. What we can say that the remdesivir is definitely not a miracle drug. It actually works. According to ACTT1 and the trial from the CAD, it performs better when it's given to patients earlier in the disease, meaning that's logically when the patients are in their viral phase of the disease. And it performs better when the patients require low-flow oxygen. It will be very interesting and very important to see the further trials, the future trials, and their result. Meanwhile, we can say that we should remdesivir our patients because there are more trials that supporting the fact that remdesivir actually works in these patients. And at the end, let me just reflect that everybody's feeling. And thank you very much.
Thank you, Dr. Tao, and to all of our guests who have joined us from all around the world. Good evening from Tel-Aviv, and we hope to be able to see you all in person in our next conference. Litraot.